Digital health would be incomplete without her views. Dr. Soumya Swaminathan, Chief Scientist, World Health Organization. Over to you, ma'am.
Distinguished guests, ladies and gentlemen, I'm happy to be speaking at the FE Digital Health Conclave 2021. It is an opportune time, really, to be talking about digital health because I think in the last 2 years of the pandemic, we have seen digital tools and technologies really accelerate.
Welcome to day two of the FE Digital Health Conclave. We have lined up some exciting speakers and panelists today for you. Let us begin the day with our inaugural address. Join me in welcoming our speaker, Dr. Soumya Swaminathan. End Summit on Digital Health would be incomplete without her views. Dr. Soumya Swaminathan, Chief Scientist, World Health Organization. Over to you, ma'am.
Distinguished guests, ladies and gentlemen, I'm happy to be speaking at the FE Digital Health Conclave 2021. It is an opportune time, really, to be talking about digital health because I think in the last 2 years of the pandemic, we have seen digital tools and technologies really accelerate around the world and be used for all sorts of new indications and applications. And so the innovation in this space has really grown by leaps and bounds, and there are a lot of expectations. But at the same time, I think we also need to make sure that the development of this sector is well governed, that there is a framework for how digital transformation of the health sector can actually happen. What are the various steps? What are the risks that need to be addressed and mitigated? And also, how do we monitor, evaluate, and measure the outcomes and impact of moving into a different mode of doing things? So rather than talking about digital health, I like to think of it as the transformation of the health sector, a digital transformation of the health sector, which actually results in better health outcomes for people. As we all know, the pandemic has not only had a direct impact on health of those who got infected and lost family members, lost loved ones, or suffer themselves from COVID, but a much bigger impact, especially in low and low middle income countries, really has been on the economy, particularly on the livelihoods of people who were already on the edge. So when we take a step back and start looking around and looking beyond COVID, we see the kind of impact that it's had, and this impact is likely to reverberate and have its lingering effects for many years. And this is where we need to step up, and this is where digital tools can play a role. They cannot be the whole solution, but they can certainly be part of the solution. So last year, the member states of the World Health Organization came together and approved a global health strategy on digital health, a global strategy on digital health, which was endorsed in 2020, and it set out a vision for where the world should be going, as well as certain strategic objectives and a framework for action and implementation. And there were four objectives of the strategy. The first was global collaboration and knowledge transfer. We know now that we need partnerships at the national level, at the regional level, and at the global level in order to align resources and investments that will ensure the sustainability and the growth of digital health. And we've seen how during the pandemic, it is the global collaboration between scientists, between academics, between researchers, doctors, private and public sector that has resulted in the development of these new tools that we are all using today, the diagnostics, the vaccines, and now the very promising new development of oral drugs for COVID-19. So certainly global collaboration and knowledge sharing, sharing of technology and know-how will help us not only in digital health but in all fields, including in climate change, where we're talking about green technologies. The second, of course, is objective is the implementation of the digital health strategy itself. And here it's about every country needing to own it, to adapt it, and strengthen and develop their own national digital health strategies in a way that suit the country's vision, national context, health situation trends, as well as available resources and core values. So India has actually been quite a leader in this field. It's been ahead of the curve with National Digital Health Blueprint, as well as discussions around data protection laws, and during the pandemic has experimented with a number of digital tools like various apps, the Arogya Setu app, for example, that was used for contact tracing, the COVID app for the digital vaccination certificate, as well as the e-Sanjeevani platform for telemedicine. We need to learn from these experiences and really think about how do we use this to tackle our other pressing health problems, and also how can we improve. So, for example, we need to really evaluate the e-Sanjeevani program, which I believe has consisted mostly of the one-on-one consultations, but there are plans to develop the hub and spoke models where the family health and welfare centers, which are being developed now, can be connected to either a CHC or a PHC or maybe even a district hospital in order to make sure that the staff at the family health and wellness centers have access to medical specialists and that patients can get appropriate advice and thereby improve the management of their health conditions or even help to prevent some of the health conditions. We've seen today from the results of the National Family Health Survey 5 that had just been released for the remaining states that on the one hand, there are some very good signs of decreasing fertility rate. But on the other hand, there are some worrying signs there of actually increasing rates of anemia in men, women, and young children, and increasing rates of obesity, both in women and men, and also worrying trend in children, while at the same time, we still have very high rates of undernutrition and stunting in many states. So it's a mixed picture. On the one hand, we do have undernutrition and stunting and wasting. On the other hand, we're seeing this increasing obesity. So we need to look very holistically at the health sector to see, are we really focusing enough on prevention and promotion of health as opposed to treatment and management of disease? And I think the digital tools have not been put to their full potential, particularly young people who get most of their information and advice from digital tools. I was commissioner recently on a Lancet and Financial Times commission on governing health futures. We're thinking about health futures which are going to be driven by digital for a large number of young people today. So that's the way the world is, the direction it's moving in. And so it's good to really think about how one can provide health promotion messages and get people to adopt healthy behaviors, more exercise, less of eating of processed, high fat, high sugar, and high salt foods. But also there needs to be policy changes, particularly in cities, to make sure that there are open spaces, green spaces, sports grounds, etc. So this is where, again, we see that you can use the digital tools, but you also need to make changes on the ground so that to make people easier for people to use those advice that they are receiving. So using the e-Sanjeevani platform also, I can see that we could also mentor and upskill our vast medical professionals, health professionals that we have across the country, whether they are doctors of MBBS or whether they are Ayush practitioners or whether they are nurses or community health workers, scientific evidence, data, and medicine is changing, growing all the time. And it is very difficult for individuals, especially in remote areas, to actually be up to date with everything. And so, using these kind of digital platforms actually for capacity building, for ongoing mentoring, and also for monitoring and course correction could be another application which should be tried and built on the existing platform. Similarly, the contact tracing app, Arogya Setu app, maybe there could be a version of that that's actually used to help and monitor TB patients or people who want to seek diagnosis for TB but don't know where to go, people who've been diagnosed and are on treatment and need to get in touch with the health provider and ask questions. Similarly, there is an app called the Simple app that's been developed as part of the India Hypertension Management Initiative, IHMI, which is now in 100 districts, dealing with hypertension, which is actually the most common risk factor and probably accounts for the largest number of deaths today across the world, but certainly in India. So, just control of hypertension alone could actually reduce the disability life years that we are experiencing, as well as reduce premature mortality. And so, using it's called Simple app because it is very simple and easy to use. It helps the patient and it also helps the healthcare worker, the NCD nurse, to track the number of hypertension patients that she has, make sure that they come for their appointments, make sure they have their drugs, and also help them to schedule the follow up appointments. And if we did that, we can reduce the burden on the tertiary health system by reducing the number of people who go into kidney failure, need dialysis, or who have strokes and heart attacks that need a lot of specialist management. The third element of the digital health strategy is around the governance, and we need to create robust and sustainable governance systems because the private sector that certainly has a big role to play here, but it needs to operate within the framework that has been developed by the government. And this is the same is true for health as a whole, but certainly for digital health as well. And then, not to forget, the fourth objective really talks about placing people at the center of digital health. So, human centered health systems that are enabled by digital health. So, we need to advance also health literacy as well as think about digital literacy and look at who are we excluding by moving into a digital era. So, gender as well as age as well as area of residence are very important. So we know from that women are less likely, they may have mobile phones, but less likely to have access to internet. That people living in remote areas, particularly tribal areas, I have visited several tribal areas where there was no connectivity, and so children could not have any access to education over the last 20 months. And the aged, the disabled, people who really cannot use the kind of digital tools that we are everybody is getting used to these days. So again, there could be that category of people that we call digitally excluded. So we have to be very, very cautious when we look at this, and that's why I said that monitoring and evaluation is important, data is important. There are a number of innovations, and I can't really talk about all of them, but more and more the use of artificial intelligence for health is becoming quite attractive. And for example, in the automated reading of x rays for TB, there are a number of companies and a number of Indian companies that now have algorithms to read the x rays and to be able to pick out TB lesions from other kinds of lesions. So, again, in areas where there's a shortage of radiologists, one can use these kind of AI-based technologies, but they have to be evaluated and they have to go through a process of validation. And this is where the public-private sector collaboration becomes important. The public sector can really help to evaluate, and we also need benchmarks. So the WHO, again, has been engaged a lot in trying to develop benchmarks for AI-based technologies. And we also have recently a document that has been put out, which is around the ethics and governance for artificial intelligence-based technologies, really pointing out what are the basic principles that we have to be cognizant of, and laying out checklists for developers of AI technologies, for ministries of health on how to validate, use them, as well as on doctors or health providers who are going to use these tools in their clinics. So this kind of frameworks again need to be developed, and governments need to look at what measures need to be put in place, what rules and regulations need to be put in place in order to make these function in a way in which they're actually adding value. So we not only need to work with different stakeholders, but need to look at the country's own priorities, where these tools can be most appropriately used, and then also developing investment strategies for one is, of course, the hardware, the connectivity. I think we need to ensure that every village in India is digitally connected. And I think to a large extent, there are mobile networks. But again, as I mentioned, there are tribal areas where there are no networks and no connectivity. And this further excludes this population who's already quite marginalized. And all of this will help to shape the ecosystem. I think maturity level for different countries is different. India is at a fairly advanced maturity level in terms of the digital health, and therefore they've taken the leadership role, and globally as well, in the Global Digital Health Partnership that India currently is the chair of, and that WHO works with. The program on what is going well, what is not going so well, which are the areas which need some correction or areas that need further focus. So while we're developing all of this, we also need to think about building that workforce of data analysts, of data programmers, and of people who can cross between pure mathematics and computation and modeling and health. So you really need a combination of these skills in order to be able to make sense of the data. So there are vast opportunities also for the workforce, because we have so many youth today in the country whose skills can be built in some of these areas which are going to be needed for the future. And this can actually be a win-win for the country. So thank you very much for giving me this opportunity of sharing a few thoughts with you. Namaskar.
Thank you, Dr. Soumya Swaminathan, for your valuable advice. For the keynote address, join me in welcoming our speaker, Manoj Kapoor, Vice President, Technology, Optum Global Solutions, India Private Limited. Over to you, sir.
Hello, everyone. Good morning, good evening, in whichever part of the world you are. I welcome you to Financial Express Digital Health Conclave. Now, we all know that Ayushman Bharat Digital Mission holds the promise to transform healthcare in India, and that's the need of the hour. It'll certainly pave the way, for the path for the portable patient health records that we are all looking for, and these are fundamental and most important aspects of building a robust digital health infrastructure in any country. So my name is Manoj Kapoor, and I'm Vice President of Technology at Optum. It's part of the United Health Group, a Fortune 5 company. Now, my journey with healthcare sector started way back in 2004 while solving the data exchange and some of the billing issues for the claims department of one of the US-based payer organization. Since then, I have worked with large payer and provider organizations across various countries, US, Canada, Mexico, UK, and of course, India, and had the privilege to meet some of the best minds in healthcare technology and solve some of the complex challenges of healthcare. Now, at a personal level, I'm extremely happy, and this is a gratifying endeavor for me, and I'm very proud to be associated with an industry that has the potential to make real difference in people's life. Now, with advancement and convergence of technology, it is rapidly becoming one of the most transformational industry of our times. Now, healthcare has been a laggard in adoption of newer technologies as compared to some of the other industries where digital has been a mainstream for many, many decades now. Now, the pandemic in the last couple of years has certainly accelerated the adoption of digital in various ways. And in healthcare, all the stakeholders, whether these are consumers, payer, provider, or government, they all have basically adopted digital very well. Now, it is a very compelling mission of UHG, and the innovative work that is being done by our company is very well aligned to my calling, and hence I joined UHG 5 years ago. Now, If you see United Health Group as a large conglomerate, United Health Group is a healthcare and a well-being company with a mission to help people live healthier lives. And this is a mission that we strive every day very hard in order to accomplish. The mission is to help people live healthier lives and to help make the health system work better for everyone. Now, we are 340,000 colleagues in two distinct and complementary businesses working to help build a modern, high-performing health system through improved access, affordability, and outcomes. And of course, experiences that we provide to all the stakeholders in this ecosystem. Now, Optum delivers care aided by technology and data, empowering people and providers and partners, and we are guided by guidance provided by all the tools that are needed to achieve best health outcomes. United Healthcare offers a full range of health benefits, enabling affordable coverage, simplifying healthcare experiences, and delivering access to high-quality care. Now, at United Health Group, our mission calls us, our values guide us, and our diverse culture connects us as we seek to improve care for the consumers and communities that we are so privileged to serve. Now, we established our footprint in India way back in 2002. Our India operations are supported by 30,000 technologists and healthcare professionals working across our state-of-the-art centers in 5 different locations in India: Gurgaon, Noida, Hyderabad, Bengaluru, and Chennai. Now, today what I would like to do is I would like to touch upon a very important topic of health equity. And as healthcare and health tech professionals, it is on our shoulders to create a more equitable future in how people access and receive care. I very strongly believe that the tectonic shifts in the policy framework and the digital infrastructure will go a long way in promoting health equity in our country. Now, what does health equity really mean, right? Health equity means helping people live their healthiest lives by ensuring they receive the care and support that they need in order to stay active and healthy. Now, this also means eliminating inequalities or unfair differences in how people access and receive healthcare. These health disparities and inequalities can be based on people's race, ethnicity, language, income, disability, sexual orientation, gender identity, and many, many more social determinants. Now, why does it really matter to us? Now, in order to support a whole person health and provide affordable care through personalized experiences, we need to address both the cultural and social barriers that often prevent people from receiving the best possible care that they can get. Now, according to one study, eliminating racial disparities in US could save $93 billion per year in excess medical costs. Now, there are certainly challenges in meeting what we call as the quadruple aim of healthcare. Like we all know, affordability, accessibility, quality of care, and the experience that we provide to all of the consumers is paramount important. From an affordability perspective, of course, the costs are kind of skyrocketing, but there are some good news also, like people are living healthier and longer. Now, when people live longer, there can be some good challenges that might come in, specifically for polychronic diseases. Now, that's a huge burden or huge financial burden on any health system in any country. Administrative cost, new drug discovery cost, and many more such costs related are adding to the ever-increasing cost of healthcare. And hence, affordability becomes very, very important topic to discuss and work upon. Accessibility is another area. Now, how do we make healthcare available to people in a very convenient manner is also very important. There are challenges with regard to accessibility, and we'll touch upon them in a few minutes from now. Now, during this ongoing pandemic, the world over, we saw a large-scale utilization of teleconsulting and also remote healthcare monitoring. But there are longer-term challenges of safety and privacy that must be quickly addressed. The other important topic is the quality of care and the quadruple aim. Improving the overall health outcomes through the care provided at the right setting at the right time through the right means is very, very important. Using modern technologies, we can standardize care pathways, offer next best actions in real time, and generally iron out human errors. And finally, experience, which is also very important on how we consume healthcare or how consumers consume healthcare, making it possible to have a very personalized experience through the entire continuum of a whole person care, which is to provide that experience at every touch point on the consumer journey. Now, how are we addressing these healthcare or the health equity? Our commitment to health equity has three main components. As you can see, access, utilization, and outcomes. Now, each builds on another to guide us toward more equitable future and make it a reality today. Now, there are well-known roadblocks to access of healthcare, we all know. There are structural barriers, such as lack of transportation, inability to find convenient appointments, technical difficulties, and lack of nearby providers when people are living in remote areas. So how do we advance access in light of these particular challenges, such as lack of insurance coverage, financial status, cultural differences, communication hurdles, there are language barriers, and other issues that are disproportionately, impacting our underserved communities. Now, access alone is not enough. If you see the other circle, which is how do we basically achieve health equity by making sure that we are providing the right kind of care, we must actually address some of the social and the health resources that these are targeted effectively and used to serve the people who need them the most. So ethnicity, culture, gender identity, geography, and age are among the factors that drive both barriers to access and also deficit in utilization. And hence utilization for the right people at the right time becomes very, very important. Now, we all know that some people avoid care due to lack of trust or previous negative experiences, and some are confused and frustrated in trying to navigate the complexities of healthcare system, especially those with complex conditions and that require a very high level of care and also a lot of coordinated care amongst various care delivery teams. So there are many reasons that too many people aren't receiving that care that they need and when and where they need it. And finally, how do we drive equitable outcomes? The right care at the right cost in the right setting, and that improves the overall health outcome. Now, these challenges may create obstacles to the health equity, and that results in preventable health disparities. So what can we do about this? Digital comes in very handy here. And that's what we're going to talk about today in this conclave, is like how digital can basically help, we can develop these particular solutions to help address health equity. Now, digital solutions, as we see it today, it is not as one thing, but more broadly as an ecosystem of various technologies, services, and interactions that allow individuals to engage with the health system in a very digitally enabled and a very convenient way. Now, if you see, virtual care broadens this particular access. And that's where we see that it can lessen the pressure on hospital capacity, provide the convenience, and most importantly, the accessibility to people in remote parts of the country. So location in most cases shouldn't be a barrier in receiving quality care. Telepharmacy is yet another way to ensure that we leverage technology to deliver medicines from a distance. The COVID-19 pandemic has highlighted the value of virtual care. Video tools, app-based acute and chronic care management, digital therapeutics, digital nurse remote monitoring, and telepharmacy all are part of the virtual care model that has helped in providing access to quality care and reduce disparities amongst various groups of people consuming these cares. Genomics holds another very promising area and a very upcoming area. So the recent advances in genomics can provide new opportunities for drug makers to reduce the time and the expense for coming up with new drugs and vaccine development. It also holds the promise of personalized medicine and a more equitable and a personal care model for managing chronic care conditions. AI and big data, you would have heard a lot about machine learning and also artificial intelligence, which is actually becoming all pervasive in our lives now. Predicting health events and creating interventions to prevent them. This goes into the AI and the big data realm, assisting in personalization of this particular care and a wonderful experience for all. A major component of health equity is connecting undeserved and communities and people with kind of services and care that they require, which can be specifically tailored to the unique individual needs. So we have created at Optum what we call as a Social Vulnerability Index, SVI in short. We have used the social determinants of health, and that has basically helped us create this particular model that helps us in in understanding these individuals better, and also help us in connecting them with the right services and the care that they need in order to take care of their healthcare needs in the long run. Use of NLP, language translation services, will be another game changer in eliminating the barrier of language and help in providing equitable care. Mobile and wearable technology is also kind of making way into our each person's life now. Mobile and these particular technologies, if it can be harnessed at scale and speed to support public health response, including population surveillance, case identification, evaluation of interventions, and even to the extent that you can actually create digital twins that can actually help you look at how the simulation in a simulated way, that how a particular person's disease is going to progress over a period of time, given their lifestyle, social determinants of health, and where they get care and how they're taking care of themselves. Now, if you see what the future really holds for us, the vision of the future is very, very clear. As I said earlier, at Optum, we are dedicated to helping people live healthier lives and helping make the health system work better for everyone. Towards that end, I think that there are several threads that are very, very important. A patient-centric approach to healthcare that anticipates the patient needs, involves the patient in their healthcare journey, help them understand their condition and include them in decision-making, and provide the best care at the most convenient location, and of course, at an affordable cost. At the same time, we want to focus on provider experience. We envision a future where doctors can spend more time, and this is most important, which is the patient interaction, and a digital health solution that acts as an enabler for providing suggestions and next best actions that actually is a decision support system which you provide to the doctors in order to take the right decisions. Finally, we want to do all of this in a way that makes healthcare much more affordable. We believe that the future of healthcare will be characterized by interplay between people, environment, and the systems, applications, and the tools created by software engineers, developers, product professionals, and also human-centered design experts. Healthcare sector and health technology is accelerating at a great pace. So I would urge our future technologists, product management professionals, and expert designers or experienced designers that if you have the passion for solving complex problems and make real impact to the communities around you, there isn't a better place to do your life's best work. At Optum, we are at the forefront of this digital health technology. And health equity has been a fundamental part of our mission to deliver whole person care while reducing cost of care. Today, it is explicit priority with clear and measurable goals. And we are making progress on those goals every single day. Each one of the interactions that we have with the consumers presents us with an opportunity to deliver fair and equitable and culturally competent care based on individual needs. It is an opportunity to consider the whole person and make a positive difference in their quality of life. That's an opportunity and a responsibility, and we take that very seriously. I hope you enjoy the rest of the Digital Health Conclave. Thank you very much.
Thank you, Manoj Kapoor, for your valuable insights from Optum's journey. Before we go to our first panel discussion, playing a short video from Optum.
Health is an important part of life. It impacts relationships, careers, how we reach our goals and dreams. Managing our health should be simple and effective, with smart, seamless experiences that connect individuals to the right care and support. By drawing from broad data sets that create a foundation for deep, insightful analysis, applying experience and expertise to deliver care plans that improve health, providing personalized services targeted to the individual, addressing physical, mental, and financial needs, reducing costs and delivering healthier outcomes. By meeting each individual where they are in their healthcare journey, by helping them to know how to approach healthcare challenges, what issue to tackle first, and where to go for help, people are empowered to take ownership of their health. And good things happen. When the healthcare system is easier to navigate, barriers collapse and care becomes accessible. And as clinicians, employers, health plans, and individuals are guided toward the next best action, costs decline and results improve. At the forefront of personalized, connected healthcare is Optum, so people can focus on what matters most.
Up and onwards to our first panel discussion of the day. By the way, I'm hoping you all are sharing your learnings on social media using hashtag FE Digital Health Conclave, hashtag Financial Express, and also tagging us at Digital Health Conclave. Thanking our partners, presenting partner Optum Global Solutions India Private Limited, powered by Eka Care, co-powered by Navia Life Care, technology partner Cloudera, supporting partner Acnamed, and associate partner Kefid. Moving now to our first panel discussion of the day, redefining public health with new parameters of digital health, including remote patient monitoring, digital biomarkers of disease, consumer tech is a necessity. It's time for the introduction of newer digital tools and technologies that hold great promise to transform the delivery of health services in the near future by improving efficiency and bettering patient care. Welcoming our panelists, Professor Dorairaj Prabhakaran, Vice President, Research and Policy, Public Health Foundation of India, Dr. B. Viduthalai Virumbi, Nodal Officer, Technical, Pollution Health Registry and State Digital Health Mission, National Health Mission, Government of Tamil Nadu, Dr. Padmaja Jogevar, Joint Director, NCD, State NCD Cell, Government of Maharashtra, and our moderator, E. Kumar Sharma, Deputy Editor, FE Digital, the Indian Express Group.
Hello, everyone. Welcome to the session on reimagining public health in India, the digital way, as we try to look at it in the context of the digital surge that we are seeing in India uh, when it comes to dealing with public health. We have various initiatives being launched by the government, the health card and various other initiatives are there. Private sector has also been taking several initiatives. Governments at the state level have also been in their own way trying to use the insurance platform and also engage with the private, but also leveraging the digital platform, as it were. So we have to discuss this topic and share their insights on this. We have a distinguished panel here, and may I begin with each of them requesting each to perhaps share some introductory remarks that they have on this topic of reimagining public health. May I begin with Dr. Prabhakaran, since he comes from, he has seen from his perspective, he's also involved with research as a public health at the Public Health Foundation of India. You've also, Dr. Prabhakaran, launched some of the initiatives in the digital health space. So if you can share some thoughts in terms of this, some of the initiatives that you've launched and the way you see this whole space panning out.
Thank you, Mr. Sharma. I would answer the question. I would take at least two questions in this. Number one is, why do we need to reimagine health systems? And number two is, what is the role of digital technologies in the health system? I think reimagining of the health system is because of multiple challenges the health system faces in this country, which includes shortage of doctors, the problem of patient awareness, access, availability, distribution, so on and so forth. And the digital platform actually provides multiple solutions to many of these issues faced both by doctors, patients, as well as the health system. And I think there are multiple roles digital health can play in the health system. One, I think it can improve surveillance, and we require surveillance for disease because we need to plan what needs to be done and what is required in the health system. Second is the chronic diseases have risen considerably, and more than two-thirds of the deaths in this country is because of chronic disease. And many of these chronic diseases can be prevented by early diagnosis and opportunistic screening, where digital health can really help. The third is in the role of management, where electronic decision support systems can help, telemedicine can help, and there are several others in terms of capacity building of the primary care physicians and other healthcare providers in the system. So I'll stop here and come back for further questions.
Thank you very much. I think that was laying the the scene, as it were, very nicely. If I can go to Dr. Virudarai, if you can just share your thoughts in terms of some of what you feel about this thing on the digital way that we're talking, in terms of the way the unfolding of the public health scenario in this space, and from a state level, because I think you and Dr. Jogav are actually with the issues are really these are subjects which are handled at the state level. Really, you are there, have a very crucial role to play, and in this scenario. You could share your opening remarks in terms of how you see the importance of this, as Professor Prabhakaran pointed out. Along with that, it will help if you can share some thoughts in terms of how the fine tuning happening for the times ahead.
Hi everyone. Presently, I'm working in the population health registry. It's a new context. So, how we are evolved to the population health? Like the public health is everyone knows after the COVID pandemic that public health is all about the need of the hour. We need experts to identify the pattern, how it is spreading, how to control the spread. So this made the state and the country to think about how to redesign the programs, how to redesign the data management, how to reach the remote people, and how to use the newer technologies on day-to-day activities. So the problem of a state like Tamil Nadu is we are having a 1 million deliveries captured every year, and all the deaths and births events are captured in an online platform. And as well as the walk-ins in the facilities and inpatients are managed digitally for last 10 years. But still, during COVID, we had a issue of speaking to each other. One program speaking to each other, one application speaking to each other, one record speaking to each other, one person's record speaking to the same person in the same hospital, but in different divisions. So all these things made us to rethink about data standardization, like how to standardize the data, how to standardize the address level, how to standardize the facilities, how to standardize the data capturing method, and we are ultimately envisaged to have once only data collection. That means if one staff enters the birth date, thereafter no staff should re-enter it in the person's lifetime. So that is a very ambitious target. Yes, we know that the state is committing for it in the name of population health registry with a health security aspect in it, because currently, like most of the public data set in a facility level, it is accessed like take it for granted. Like for example, if the record is available in a table, any person who is having access to the table can now read it. Similarly, if any person is having access to a window, they can able to access the record. So now we need to give assurance to each and every public that there will be a privacy, there will be a consent. The consent is ill-defined in the health sector because ISO gives some guideline on it, how to have a consent. But in all other places, it is getting a OTP is considered as a consent, or putting an accept button and clicking on it or tapping on it is accepted as a consent, or getting a signature in a paper and telling that taking a photograph of it is the consent of the individual, whether there is any expiry for it, whether this data can speak to the other programs, whether this data can be reused or repurposed for the future requirement. So these are some ill-defined areas. So these gray areas has to be cleared out, ironed out, and we have to formulate a standard. And with this, I think the population health registry has been issued as a government order. So there comes the commitment for a health security initiative. We know the technology is there, but with the note that the staff are not friendly for technology because they are more concerned on the human lives than sitting and tapping or entering the details into a portal or a platform. So we also need to think about what is the get back for the staff. Like if I enter a word, what I'm going to getting back from it. We are committing for no manual reporting. So that is what the future we are thinking. So this is again a very manual and massive exercise which we are going to do to move to no manual reporting. So I'm telling that there is a manual reporting. We need to physically verify individuals. We need to physically verify records. After some point, we can commit for no manual reporting.
I think it's a long journey and a arduous journey actually, but it's very nice. You've explained it so well, and that's very nice actually. Dr. Zogewar, actually, if you can share your thoughts in terms of how you see this digital journey unfolding in your state. I mean, you have there are I mean, you have not just the pandemic, but this is multiple dimensions are there, and this the from a healthcare perspective. What has been your experience in terms of the way you're seeing the digital platforms and the digital compulsions actually on public health delivery? What's been your experience in terms of how it's panning out?
Hello everyone. Digital platform is good, but there is so many hurdles, or we have the so many software, so many data entry point, but they don't talk with each other. The data will not talk to each other with any of that. Because of that, every person had download the data and mix with the. If I have the plan to something, just say I work as a NCD, so I know the hospital data where the hypertension patients are more, diabetic patients are more, or I required. Yeah. In Maharashtra, we have the lot many things in the Maharashtra. We initiated the e-office in Maharashtra, e-aushadi, DVDMS software which also uses. Uh, Also the telemedicine from 2007 to 6, we are using the telemedicine in which we have developed this spoke and hub model in that. During this COVID, we also utilize this facility for our patients management. Uh, but uh, but PCPND software will be also there, sir. But we don't. We have not a single nodal. Ye, the software will not talk to each other. Data will be there, and data filling has another problem. We have so many. Sorry, we have the so many software in our department and different languages. The language will not be, this software data will not easily transfer to it. This one of the problem is that the NCDIT portal government of India has given us, we around 2 crores people we are enter in that IT software, but the follow-up of the patients is not there. It is very half-heartedly, so that's why very half. It is not completely formulated. That I have not take any review from that. Ki how many patients are put on the treatment and they are under control or not, or they have developed any complications or not. So the software is built there, but the new features must be added on it. And this software, thus NCDIT software will be, HWC software is another, that the same data will be entered in that HWC software and NCDIT portal. So same the people, we are giving the services to same people. So we must have a national ID, same for the all. All the information will be there. That personal information of that person is there. Just I also looking after the mental health. In mental health, we are trying to develop one another software, that is the for the e-manas software, which is for the all mental hospital should be registered there. All the mental services given by the people, jo institute are giving the services. This is psychologist. All were registered on that same platform, and the patients, those are admitted even in government hospital, even the private hospital, they are giving the treatment to the mental patients. They all patients are registered in that. There are so many challenges and so many uh,
Very much.
challenges to complete
Yes,
this
yes, I
thing.
can totally understand.
Yeah, so
Totally
I
understand.
have to encourage everyone to please and training, capacity building. After doing that, the software will be completed. I think all the entries will be completed 2 to 5. They may require the 2 to 5 years. Just
Yes,
and that's the dilution of that program is there.
yes, absolutely. No, I
Yeah,
can
so
understand
that's
it.
why the key one software, single digital platform is there, and everyone should get the information from that.
Right, very
The
true.
same population, we are creating many
Computers.
for every program. We have the different
No,
software is there.
I think no, very
So
important.
all states may are facing. The Maharashtra is the facing lots many problems.
I can understand now. Very important, actually, Dr. Prabhakaran. This problem which is there actually has been, as you would have noticed, the states, this data not talking to each other, these platforms of therefore little follow up which is possible now. These kind of issues. Uh, you've heard some of the pain points which are there when one comes to what, in your view, are the possible solutions for it? How would you think as the best way to approach it?
So I think if we have to encompass all that has been said, all the challenges that have been said in one word, it's interoperability. I think the key word is interoperability uh, because the devices, the software that they're made in different languages. The devices are made in different ways. So we need to make a way in which uh, every um, every software, every device talks to each other. And that's where, I mean, I want to give an example of how we have overcome that. So as we know that telemedicine has become very popular during the COVID pandemic, but there are challenges to telemedicine, especially on the part of the patient, because there is digital illiteracy as well as there is low level of education. Amongst the doctors, there's a challenge because they don't get all the information that is required. And for the health system, the challenges are interoperability. So in our telemedicine system, which we call as Digi Sahayam, which is being used in Chennai and in southern Tamil Nadu, where we have put together all the innovations that are there. That includes electronic decision support system, point of care devices, AI-enabled ECG system, an electronic stethoscope, and a high-definition camera. We have created a software which is interoperable, such that each of the devices, you can extract the information into the software and it provides a composite information to the doctor or to the patient or to the health system as required. So it just requires a little bit of imagination in terms of making this happen. The second challenge is every department or every person wants hundreds of information to be put in. I think there needs to be an apex person who decides that that there has to be a small amount of information. We cannot put too much of information, because most of the information is really redundant, repeated again and again. So I think you require a multidisciplinary team within the ministries to work together to get that kind of an output and use that output. I think once we achieve interoperability, we can overcome most of the problems that have been put forth now.
Yeah, but from a state level, you alluded to this point that you've actually overcome this problem of interoperability. At the state level, when states are talking of this challenge, it has to be something which is financially viable at the same time, also which can be over a larger audience, the population wise. What would your suggestions be? Like, what could be some of the things that in what direction solutions can be found?
First is creation of a dashboard. I think you really need to create those indicators that are really required for the health system. Once you create the dashboard, populate it with all the things that you want, you can actually prune it ultimately and use it. Right now, the infrastructure has been developed. The e-Sanjeevani is already there in terms of the telemedicine platform. There are many other innovations which are being introduced. All that is required is a dialogue between the various stakeholders in terms of harmonizing the data that they would want. And that can be easily achieved. Cost is not an issue at all, because once you create, the cost is the one-time cost in terms of developing these infrastructure. But once it's done, it's just the creation of updation, basically, in terms of new information that may be required. There are challenges, of course, like, for example, names. Names may be very similar. So and the thing is, when you have enormous data, it's difficult for the person who's inputting the data to actually search. So there are new mechanisms that are available, such as fuzzy logic, which is used in technology, and that actually helps. Once you just put an R, for example, you will get all the Rams there. Then you add something else, you will get everybody there in that list. So there are solutions. I think what is required is a multi-sectoral dialogue before they start off. And instead of using a top-down approach, use a bottoms-up approach where you have all the people who are different groups of people who are involved, have a consultation with them and develop the tool.
Thanks so much. Dr. Virudharai, the way Dr. Prabhakaran has pointed out, in some of the newer initiatives that you're launching, I mean, there are several which I think Tamil Nadu government has actually come up with in the recent past as well. Is there a rethink in the way you are approaching this? Are you what kind of solutions are you contemplating?
Yes, sir. I go with Prabhakaran sir word is mainly the interoperability, because the data standardization is first step. The second is to ensure the interoperability. I wish to add that the standardization, we got an analogy that if our 130 plus health programs in the states are speaking to each other, then you think about the phone which is being used by the staff nurse who is handling all these 100 plus programs in a primary health center. She will have 100 applications which will speak to each other, which will be interoperable, which will be standardized, but 100 applications has to be used by single staff. So this is, we try to integrate, like if the fields are common, if the applications are having the same fields, we integrated 4 such applications into one package, because that is a universal health coverage of Ayushman Bharat component of the state, Makkale Thedi Marthum, which is doorstep health service delivery, and population-based screening for priority diseases, and population health registry, that is a family register in the each subcenter. So now all these 4 is going into a same application, but there is a packaging is required. That means if a user need to be created, then suddenly no one should call to the state and ask for, hey, please create me this user ID. So now it has to be decentralized to the block level. So we need to have a block level team who can able to manage all these users, facilities, the facilities jurisdiction, that is the streets and household groups, then who is catering these streets, and which of the other sectors who are working closely in that field. So that is first package. The second component of the package is the data entry, which require offline first, as well as they need the search in less than 1 second, as well as it has to be the mobile application. So think about this. These 3 features are contradicting, right? You need to have an offline as well as you need to search the old state. That is, we defined all this first. That means offline is the first feature, quick search is the first feature, then the mobile app is the first feature. Then whether there is welcomingness for this data entry depends on the monitoring dashboard. Everyone need to know what I performed today, where I have to go and do the service delivery. Then the learning will happen side by side. So we don't have a separate learning management system. It has to be there as part of the package. Then ultimately everyone need to have a place to complain, because people are more happy when they're complaining or when they're reasoning out this is failed or this is additionally I want. So also there require a project management. You obviously know that the funding, everything has to be monitored. So we need a project management tool for executing this. Yes, if you ask that with this package, if a staff will use this, no. They want to first remove whatever the additional reports they are making out of the same data set. So we thought of whatever the disruptions happening by this digital technology, right? We introduced the word participatory designing and research. We sat in a block, rural block, for almost 4 to 8 weeks with each and every staff to know how many registers they are using, how many fields they are reporting, how many fields they are collecting. You will be surprised after this exercise. They don't need to collect 15 fields. They need to collect only 3 fields, because all other 12 fields are exist in some other register. So in this participatory designing and research, we can able to bring the work time reduction, the satisfaction, and more productivity in terms of service delivery. But what will happen to the small clinics? Who will able to empower these clinics? Who will able to give this kind of software for a private sector? So each and everyone is paying out of their pocket, and it will be anyway indirectly going to be paid by the general citizen. So here government has to take lead for most of this IT infrastructure, because the payment of most of these digital tools is the same application will be given a different color and logo and some kind of user interface and used in different places. So now if government is taking lead, like Ayushman Bharat mission is taking a lead to provide the neutral infrastructure. Yes, small clinics can be benefited. They no need to have a separate software, servers, gateways, data sets, and it will be secured also, because investing on the security is a very high cost for a small clinic. And if you ask me whether this is sufficient, no. The person who is going to the doorstep or delivering the service needs intelligence at their hands. Now we are thinking that the intelligence, the artificial intelligence, everything is at the computing capacity of some bigger servers. Now our staff who is handling all these programs need the intelligence in the handheld devices like a mobile phone, tablets. So which require some kind of a digital ecosystem with open source standards. Yes, obviously, like we cannot customize for each and every program to speak to each other. So we need to follow certain standards so that we elevate everyone to a level where the general citizen will get benefited. So again, it is again and again, I'm insisting that digitization is not a big task. In railways, it is digitized. In many sector, it is digitized. No one is booking their ticket of going to the counter. But when you see, if you want to get a OP ticket, you are going to the counter. Even in a private hospital, you have to reach the registration desk to get which consultant you are going to consult. So here, digitization is as a whole, not a tool, not a software. It is going to be the ecosystem. So where there are three major players, like the beneficiary. We don't use the word patients because most of them are well or ill. So we use the word beneficiary. The second person is the provider. Yes, in some states, the state is also a provider. So when we tell the state, people are thinking state is a government, right? We are also running the primary health center. Who can run the scale of the provider for 8 crore population? Like 7.6 crore population are benefited by the state. So state is also a provider and state is also a government. So here, these are the three players, right? Government, provider and beneficiaries. We have to think them as an ecosystem.
Very well. I think we covered a lot of ground here. Just one quick point before I go to Dr. Zogevar and then to the concluding remarks. This under this recently launched initiative that Makai Tedi Mardavam, actually, where you actually go house to house, and I think even BP and diabetes, all basic things are also recorded, and we have information. Is this done digitally, or what is the plan there?
Thanks for raising this concern, sir. We are in a phased manner approach. Like I would like to tell that we are empowering the woman who is locally residing in a village and in the urban area. They are from the self-help groups. So the state is now empowering the self-help groups to step into the health domain. We are training them and they are going to door for checking the blood pressure and the blood glucose. Now, as a first step, what we have done is the program clarity is being imparted in last 3-4 months. It is being there, and in a phased manner, we are moving them to a digital platform. So now the women health volunteer are encouraged to make the entries in the mobile application, so that they will know whether the BP is under control or not, whether to deliver the drug or not, whether the blood glucose entered is within the control value or not. It is a aiding tool. So now it is being digitally captured. That first cycle is only a programmatic approach. So first we clarified all the protocols. Now we are moving to digital medium. Then the next phase is we are going to profile every one of the citizen in the state and funnel down to who are the actual needy people under this scheme. So the digital tool will give you who are the suspected, who are the confirmed, who are the beneficiary, and who are the dropouts. So this delta of dropout rate, that is what we are thinking advantageous under this Makaliteri Marthum program.
Very important. Thanks so much. Thanks for explaining that. And Dr. Zogevar, what is your learning from what you've gathered from the various approaches? Each is wanting to intelligently move around and find solutions, like Dr. Prabhakaran pointed out, in terms of the way one can leverage and find a way around it. And in Maharashtra, actually, they have used self-help groups and how they are trying to leverage various strengths in terms of when trying to come up with program initiatives. Anything new that you are attempting when you look in terms of now the public health, which maybe not now but going forward may have to can stand on the digital platforms which will eventually come into place?
We are trying to make an digital ID of every person's. We are entering all the people 30 plus in the NCDIT portals. As I am looking after the NCD program, so I'm saying that around more than 2 crores people we are screened in Maharashtra, and enroll. All the CBAC forms are filled by our ASHA workers in rural area. In urban area, we started this year only. that urban population of slum areas and the high risk population of the urban, we are entering this software, sir. And we are trying to reach up to the rural population, 100% rural population, sir, and urban area 30% population. So we started just now in the corporation area this year, but in the rural population from 19, we started this population, the screening. All the persons CBAC form is filled, and the CBAC forms are all from 0 to all any age group. The CBAC form is filled, and that the this form will be filled by the ASHA, and this 30 plus, all the people in the 30 plus, the ANM, MPW, and now the CHOs come in the field. That the CHO will they test the hypertension, diabetes, West Suncarbons, and all the history of that high risk tobacco, chewing, alcohol, and all the information we are getting from them and enter into the software. And now we started the giving the health ID number, national health ID number with the Aadhaar link mobile phone numbers. So we are facing lot many problem in that. Only we are completed met, I think 5,000 people we are giving the national health ID, in which all the health information of there of that person is there. And if it is possible, if it I did the 100%, then the system will be, and this with the health ID, the information will be transferred to other software. And also, so this is one of the challenges things I'm facing, that very slowly the people are the encourages. There are some difficulties like Tamil Nadu, the Maharashtra is backward in the IT sectors. Tamil Nadu people are very, yeah, we are facing the data entry problem and validations of that data. We are giving the all the three-tier system, the PSC. We have the three-tier system of that, but in third tier, that is the tertiary care, that is the medical college, we don't have that facility. They have their internal facility in that individual college, but our patient is not linked with them. Unless and until I completed the national ID, then the patients will, where the patients get the treatment and all that I will know. So we are starting just, sir. We have the IT peoples, they are doing better, and even vital strategy people are also helping us for that. We are in very initial stage, sir.
Yeah, but I think with greater coordination, greater collaborative approach, as you're saying, you can probably find solutions, which is a good way. We are headed in that direction, which is good.
We are getting the solution, but very slowly. We are moving very slowly.
The pace has to be. Dr. Prabhakaran, you've this issue which is there in terms of, you've seen the way the problems are happening at the state level, but the issue is also of the healthcare cadre. I mean, we are again going back to the ASHA workers. We're going back to the self-help groups or whatever. Your view in terms of when we talk of a digital health and public health environment, what's your thought process in terms of building a healthcare cadre which can also perhaps play a crucial role in this? Any thoughts there? Is that a way to look at it? And any concluding remarks you might have for in terms of people to take away in terms of the way we look at public health when we are trying to embark on a digital pathway, as it were?
Right. I think I'll make three observations. Number one, in terms of your question about whether we need a new health cadre, I don't think so. I think we cannot create a health cadre for every change that we introduce. And basically, I think we need to advocate and train them to use this and tell them that these are for your assistance and not for increasing your work. Because the biggest worry in the healthcare sector is that does this work increase our workload? So I'll stop at that.
Dr. Prabhakar, I was not saying in terms of creating a new healthcare cadre. Could be incentivizing the current healthcare cadre itself.
Okay, we need to. Yes, we need to incentivize, and we need to think of ways, because I think many of the government systems are kind of molded. It's a little difficult to change, so we need to think out of the box in terms of doing that. But coming back to my concluding remarks, I think whatever we do in the digital space, I think we need to address a few things. we should always be cognizant of the quality control in terms of providing the care. It should be scalable, it should be sustainable, it should address contextual needs. And again, I come back to interoperability. It should be interoperable, it should be easy to use, it should be not costly, and it should address privacy issues. So I think essentially what we are saying now is that technologies are inherently reductionist, but the solutions have to be holistic, and we have to find that solution using whatever wherewithal that we have. But the most important thing about whether we use digital technology and whether we reimagine health system, I think the most important thing is patient centeredness and continuity of care. I think these should be the mantra that we should have when we digitalize our healthcare. Thank you.
I think that's very important, and I think both Dr. Zogawar and also Dr. Vedana, I think would agree that I think in most of the initiatives that they're talking, that keeping the patient as the central entity to be addressed. And I think this whole issue of interoperability, and I think the way they are, while as Dr. Zogawar says, it will take time perhaps, but I think that's the journey which I think we all need to embark on. But thank you so very much for your time. I think it's been a useful session. We've tried to, gain some of the insights in the way the challenges are to be dealt with going forward. Thank you so very much for your time, Dr. Prabhakaran, Dr. Virudarai, Dr. Zogawar. Thank you so much for your time and for sharing your thoughts.
Thank you, Mr. Kumar and the panelists for the session. Before we proceed, playing a short video now from our sponsor, Eka Care. Moving on to our next panel discussion now, digital diagnostics towards a holistic digital health ecosystem. In a country where data collection is a round the clock activity, there is a huge opportunity for digital diagnostics. Usage of technology to enhance the value of diagnostic data by presenting it in a more comprehensive manner can bring down data to a much more efficient use. Digital diagnostics can significantly influence clinical decision making by providing a range of tools for the aggregation, presentation, and interpretation of patient data, including tapping into de identified patient pools or curated tumor mutation datasets, matching patients to clinical trials, and facilitating multidisciplinary collaboration. Presenting our panelists, Dr. Kamini Valia, Senior Scientist and Program Officer, AMR, Indian Council of Medical Research, Andrew Cross, CEO, Everwell Health Solutions Private Limited, Rashi Garg, General Manager, Kefid India, Dr. Debishore Gupta, Director, Medical Affairs, Kefid India, Dr. Raghuram Rao, Joint Director, Public Health, National Tuberculosis Elimination Program, MOHFW, Government of India, and our moderator, Neeraj Jain, Country Director, India, PATH.
Very good morning, everybody. Great to have you all here. And of course, what a rocking panel. We have Dr. Rao from the government, from the DB program. We've got Kamini from ICMR. We have Andrew from Everwell. And of course, Dr. Deb from CEFID. So thank you so much for joining us. Today, we're going to talk about digital diagnostics. Very, very important conversation. Really talking about a holistic digital health ecosystem. So I'm looking forward to this conversation, and I'd like to start by actually asking the panelists for some of their thoughts around this topic and how they see it evolving. So maybe we can start with Dr. Rao. Dr. Rao, let's have a few minutes of your thoughts.
Yeah, thanks, Neeraj. Digital, interventions that have come into the healthcare sector have been so revolutionary that it has changed the way diagnosis is made. It has changed the way health is looked at from the doctor's eye. There's a lot of AI. There's a lot of platform technology. So many things coming up that diagnosis is more now digitally driven than the dependency of the or the erstwhile on the clinical skills of the doctors to interpret a lot of things. But digital health has helped where the healthcare sector itself is a lot more scientific and evidence based now.
Thanks, Dr. Rao. And of course, it complicates things because you need rules when that happens, right? How are the rules going to work, privacy, etc., etc. I'll move to Andrew. Andrew, can we have some thoughts from you on this?
Absolutely. Thanks, Neeraj. So I think high level, as Dr. Rao mentioned, it's been really exciting to see what technology can do for public health, and I think we've made enormous progress. I guess the themes for me are always, what more can we do, or where are the gaps that we need to be focusing on? And for me, those are kind of two. One is that there's enormous focus on the data in side of things. How do we capture these data? How do we collect it? I think be really excited to see more energy around the data outside of things, which can include AI and ML work, but is more about engagement. If I have a diagnostic result, how do we make sure that a beneficiary or patient knows about it? How do they know about next steps? How do we connect them to treatment after receiving their diagnostic? And I think the second side is that while, again, there's been enormous progress, it may not be uniform across diseases or across different segments of society. You can imagine a very high-end hospital or healthcare experience where you have lots of tools available, lots of technology for you, but how does a lower income patient or someone who doesn't have a smartphone, how do they access health records and kind of their start of treatment? So I think those are two very exciting things to focus on as we look ahead.
Fantastic, Andrew. So yeah, data in, garbage in, garbage out, important thing to remember. And also, of course, democratization is going to be absolutely critical. How do we get equity as we move along this whole story? I'll move to you, Kamini. Let's hear some high-level thoughts from you.
Thanks, Neeraj. So I would like to highlight the public health aspect of digitalization of diagnostics, I think. Because for a long time, the entire approach around the public health was treatment-centric. It's only lately that we started giving push to diagnostics. But then COVID actually brought a lot of spotlight on diagnostics as well as the importance of the IT infrastructure, because not it allows us to share results or share our findings in the real time, but it also allows for a better analysis, I think, a more bringing in all the aspects that we need to understand with regard to a particular disease or a particular health problem. For that, I think IT and digitalization will be very, very important. Otherwise, most of the time, as you mentioned, the word democratization, what we are seeing is that we are seeing the diagnostic results or evidence from only a very scant kind of scraps that are coming to us. It is only a very small aspect of diagnostic information we are able to access, and it is never panned out evenly to all socioeconomic strata. So that's why I think now is the time to add digitalization or IT infrastructure and systems to the whole landscape of diagnostics, which Government of India is actually very keen on promoting.
Thanks, Kamini. And it's not going to be an easy task. We are a big country with lots of people, lots of disease burden. I mean, while we are middle income going into an economic economic power engine, but we do have challenges with our health indicators per se. I'll move to Deb from Cepheid. Deb, would you like to come in?
Yeah, I think digitalization is the true way forward, and this is going to revolutionize. And we have already experienced sufficient maturity during this COVID-19 pandemic. So essentially, this is overall simplification, keeping the quality intact. And definitely the greatest beneficiary is going to be the patient. So patient management is going to be simplified, it's better, and this is how we perceive digitalization.
Fantastic. Thank you so much. Great opening remarks, and of course, brings the whole idea, the concept in upfront. I'm going to jump in and ask a few specific questions, considering the panel we have and the background they come from. And Dr. Rao, I'm going to start with you because you have actually been at the forefront of using data digital for the National TB Elimination Program. I just want to understand, or maybe for the audience, using electronic patient management system, which you have, which is Nikshay, and of course, one of the best in the world is what we hear. Um, how has it benefited patient management? If you could give our viewers a little bit of an idea on, how that's happened.
Yeah, thanks, Neeraj. I mean, it's probably one of the largest programs where we actually have case-based information. I'm not aware of any other national program where we have so much of that many size of information. We have also the mother-child tracking system where high-risk pregnancies are tracked. Similar. So very few programs have in the public health perspective. You have a lot of case-based information systems in hospitals, but when you want to apply it on a public health program, it becomes very very different, very challenging, and it has helped immensely in the sense to track the epidemic, track where the cases are coming from, how is the transmission dynamics. It helps us do that from the public health perspective, and from the patient's perspective, in terms of clinical management for the doctor to see, it's so it makes easy for him to because it's a long term treatment, to track, follow up, and to look at all the clinical perspectives with the lab results, the comorbidities testing, and the adherence pattern. It's very important when chronic diseases that you monitor treatment adherence, and digital tools have helped revolutionize. Earlier, you had intermittent therapy and physical DOT, where directly observed treatment was happening. But with digital interventions coming in, now it's more of ROT, remotely observed treatment. Not literally the word ROT, but yeah, it's remotely observed, and that changes the dynamics where I can efficiently use my public health system staff to prioritize patients, to focus on those potential patients who have a higher risk of defaulting, a higher risk of death, and this changes the entire way with which we manage patients. So that's been something which in 2012 we started off, and this Nikshay version has evolved over a long over this period of last 7-8 years. A lot of new things, new features as the program evolves, newer elements of program implementations, preventive interventions like the TB preventive therapy has come in. Drug resistant TB is so dynamic, multiple episodes for a particular patient, and then different ways by which the case can be diagnosed. So having all these things into one system makes life easy for the doctor and the patient to see that in one screen. So that's the beauty of the system, and it interacts with many other national programs also as and when required to help program management perspective. So that's been the key features of our IT software that we have.
Fantastic, Dr. Rao. And of course, I've been with Path now for over 5 years. So I've been following the journey of Nikshay, and it's absolutely amazing what it has done. And you're right, there are a lot of countries who are actually looking at it and saying, we would like to. I know I've been talking to for some of my colleagues in Africa, and they're kind of saying that's what we want. So absolutely fantastic. Great. I'm going to move to Andrew. Andrew, if you think about digitization and connectivity in our country, what are the current gaps that you see, the big ones? If you could name a few, that would be great.
Absolutely. Yeah, I think as far as connectivity is concerned, there's obviously gaps in just full coverage of the country, but that's diminishing over time, and that is a reality that we all need to face. But that's something that's kind of more infrastructural. Around the digitization side, I think as Dr. Rao mentioned, it's been fantastic progress by the National TB Elimination Program to build out this technology and kind of deploy it, and really again focus on kind of better care for patients. That's the whole goal of it. It's not technology for technology's sake. But I guess even, my role in these conversations is as a technologist helping advise and build these systems. And ironically, I think the technology is one challenge, but it is just the first one. I think really the gaps beyond that, beyond digitization, kind of, carry over into the human side of things. I mean, firstly, you need this technology in place, which is there. It has to work across devices, across connectivity. That's one challenge. But then beyond that, you need systems to be reliable and also people to trust it, to believe in it. If you're going from a paper-based system to a digital system, is there really trust that I can rely on this system to keep all of my data? I don't need backup records. I think beyond that, you also need enormous capacity building and training and kind of support for this. It's not as simple as sort of taking away paper and throwing in a laptop. You need enormous, infrastructure around training and capacity building and support for how to use these systems. And to do that, you need a very, very close kind of ear to the ground or relationship with the users. You need to understand what are their challenges, what are their needs. I think that's something the program's been prioritizing. That's been a really important gap to continue addressing. I mean, are these forms, applicable to them? Is it too long? Is it appropriate? Is it helpful in the field? So I think that's one big gap, is around not just development of the technology, but kind of implementation, capacity building. And I think I kind of mentioned this in my opening comments, but the second gap that I see is, again, all of these efforts to digitize data, but what do you do with that? I think there's a gap in kind of interconnecting those systems. You might have a diagnostic system, which is fantastic. It's capturing data, but is that connected to treatment initiation? Is that connected to adherence and refill support? Is that connected to counseling services? So kind of what do you do with this data, afterwards? More about engagement. If I understand when someone has started treatment, I know their regimen, then maybe I know when their next refill should be, and I should be reminding them that. And by I mean, the system, or kind of a combination of the human and the system. What counseling services can you provide based on the information that's coming in? Are there comorbidities and therefore referrals to other services? So again, that's the first step, is there around digitization. But I think the next step around, really using the information to better support a patient, I think that's another gap that we're very excited to continue addressing.
Fantastic. So it's all going to be about the humans. So it's not like the humans are going away. Thank you. Thanks for that, Andrew. I'm going to move to Kamini. Kamini, you are one of my heroes, because antimicrobial resistance going forward is going to be one of the things that's going to really haunt us. And I just want to, you have set up an AMR surveillance system of some sort. I just want to understand if if you have diagnostics, which is connected, which is digitized, how is that going to help you in your fight against AMR? And what are the thoughts going forward on that?
Very important question from perspective of antimicrobial resistance, and actually it gives me an opportunity to share with you the challenges that we have been facing with the AMR surveillance network, the way it is currently structured in India. As I said in my opening remarks, that we most of the time the IT is limited to very specialized and very urban kind of settings, and it really doesn't represent what is happening in the rural settings or in the low socioeconomic strata. One thing is because even the labs are absent in our the settings which are beyond the urban settings, and secondly, the IT hardly exists even within the hospitals which are there in the urban settings. For that matter, many of the public sector hospitals do not have health information systems which actually connects the dots for each patient in the lab and in the hospital. So that kind of divide, that kind of gap really haunts the data, the evidence generation for AMR in India, because we still do not know how many patients come with past hospitalization, what is exactly the burden of hospital-acquired infections on MDR rates, or for that matter on the morbidity and mortality, because that kind of connect is missing in the hospitals. For the private sector hospitals, they have been able to put together good information systems, and there is way to access that data. But this whole thing is completely missing in the government hospitals. As a result, even if we present data which we say it is a tertiary care data, the data is not complete. It is incomplete in many aspects. The second most important challenge in AMR is how do you connect the trends and the patterns of drug resistance with the antimicrobial consumption? So that is something that we are actually struggling with. Now, coming to the diagnostics part, I think even the diagnostics which are currently available, they are not being utilized properly because there are no algorithms, there is no guidance on how to use that. So there's one project that we are doing currently with Find, in which we are looking at how you can utilize the commercially available diagnostics to create a clinical diagnostic algorithm, preferably an electronic algorithm, and how it can be how effective or useful it is on the ground to rationalize antimicrobial prescription. So this study is going on in 4 sites, and it hopefully should give us confidence that electronic clinical diagnostic algorithms will be very, very useful in our country and can actually reduce or rationalize, I would say, antimicrobial prescriptions. So this is where the Indian system of the AMR surveillance that we have put together from ICMR is actually, it can benefit hugely from digitalization of diagnostics in terms of completeness of data and the epidemiological aspects, which we are not able to right now understand because of the missing fields or the missing information.
Great, and
Thank
I
you.
wish you all the best for this journey, Kamini. It's going to be absolutely critical for the Indian health system as we move forward. I'm going to move to Deb, a little bit about the cost of patient management and how that would change with the digitalization of diagnostics.
Right.
Thanks.
Okay. Thanks for the question. See, we have to understand the difference between perceived cost and actual cost. So now we know that this cost effectiveness, right? So this depends on various factors. So the cost of skilled manpower. Now that we have understood that during the second wave, especially that uh, manpower resource was scarce. So this is a true preparedness that we can spare if you can save the skilled manpower. So you can actually free the skilled manpower, and you can optimize the right treatment at the right moment. So that's also very, very important, and it has got implications both on the patient as well as on the hospital or the lab, or the rather overall diagnostics. Now, the trial and error phase gets obviated when we start the right syndromic approach. I'm talking about certain, assays like expert 4plex plus. So, you can detect COVID, flu, and RSV at the same time. So, essentially, each disease has got different pathways of care, right? So, this trial and error phase gets eliminated, and overall, patient is benefited. You can start the right treatment at the right time, and morbidity and mortality definitely goes down, and we all understand human life is the costliest. And finally, from the diagnostic or the lab or hospital point of view, so it frees up the beds, the length of stay that goes down, the time to reporting, so that also goes down, the ease of use. So overall satisfaction, overall effectiveness goes with this automated digitalized solutions.
Thank you, Dev. That's very important, and yes, absolutely, it's more about the ecosystem play. Dr. Rao, I'm back to you now. We've done the full round, and back to you. Um, the whole idea here is we started, I think, in the TB program, we started with the urban areas diagnostic, then we went into districts. Now we're going sub-district. So I just want to, from your point of view, from where you're sitting, how does decentralizing some of the diagnostics and really moving that data piece forward, how is that going to help our testing and screening process in India? So if you could talk a little bit about that.
Yeah, I mean, that's a very, very important aspect, because it touches the SDG 3, where a lot of our patients now, to get the advanced diagnostics, TB initial diagnosis happens, but for the advanced drug resistance patterns, to understand drug sensitivity, they need to come to those molecular diagnostic machines are only at the district level. Now we are slowly expanding it to the block level. But imagine a time when, at the first point of entry or touch point to the healthcare, at that time itself you get the right diagnosis, and you have your sensitivity patterns, and that helps you put the patient on the right treatment. So that's something which is aspirational, and we're trying to reach those levels with the universal health care. And decentralizing, even the diagnostics are evolving. Now you have a lot of challenges as you go down the healthcare system, of connectivity, of electricity, and uninterrupted electricity. All those things are very, very critical for certain high-end equipments or diagnostics to function. But you see that the diagnostic industry has evolved with more point-of-care machines now coming, battery-operated machines, handheld. All these things will help decentralize, investigations which erstwhile, whether it's for tuberculosis or other things, there are many investigations that can go right to the doorstep, and it can really help the turnaround time, and it can help the out of pocket expenditure that a patient otherwise would spend by traveling right up to the district headquarters or to the block headquarters for getting diagnosed, and then take the treatment and then come back again for follow-ups. So it can hugely impact the SDG 3 that we have, in terms of the health indicators and the out-of-pocket expenditure to reduce that. That's one of the key important indicators in the tuberculosis program, which this decentralization can immensely help.
Yeah, absolutely. And, we are, of course, we are in the middle of conversations about a new variant of COVID. And all of a sudden we are seeing, so we are probably going that direction. And then, of course, data and digitalization is going to be absolutely critical, because how are we going to put it all together? So
absolutely, COVID has taught a lot, where the importance of all these technologies, the importance of having it at the district and below level. So it's definitely a learning which the government is investing in. Yeah,
absolutely. Thank you. Thanks, Dr. Rao. Moving to Andrew. Andrew, I know this is a subject very close to your heart. Patient health records. Well, very close to all our hearts. So I was working in public health. But to ask, how are we going to work around confidentiality? Because I think that's one of the things that is actually holding us back. Any thoughts on that?
Yes, absolutely. And as you said, a very important topic to all of us. I think for confidentiality, there are a few elements to consider. Excuse me. Firstly, is the data secure? I think that's a bit of a technical question, but something that we can solve, but just ensuring that the data is secure. I think the second issue, of course, is who owns the data or what can be done with the data. That's more of a policy level thing that needs to be decided and kind of understood at broad levels. And I think a third, maybe hidden part of that is everyone aware of number one and number two? If you're the beneficiary, if you're the patient in the hospital, do you understand how secure is the data, or who owns the data, and where will ultimately go? So I think some transparency on that level. And I know there's been lots of progress and conversations around these three, but I think that's, very important and needs to continue, and frankly needs to get resolved, because it's still, I think, a lot of interpretation ambiguity there. So I think the more we move on that, on this kind of spectrum towards concreteness and transparency around these policies, I think that'll help the technology innovators. It'll help the end beneficiaries to understand kind of their rights in the data. I think around just patient health records, actually, one of my points, Dr. Kamini already mentioned very, very, well, that in the field level, there's just challenges kind of connecting the data or building a holistic picture of what is the health of a person. In any doctor, which I am not, but any doctor, would really want to understand the entire picture before making a diagnosis. It's not just kind of what does the machine say? And so if you don't have access to that information, it's harder to make a better diagnosis or provide the best care. So I think that's one challenge. And while, again, there's been amazing strides kind of in digitization of the health record, that's one non-uniformity that I see is, again, connecting this information. I think the other non-uniformity, which I mentioned before, is just across segments of society. So, while many people may have access or increasing access to their health records, what about, lower income patients or people who don't have access to smartphones or kind of getting their care in hospitals that don't have these digital systems? How can we think about equity in that sense, where, access and health records should be transparent or available across society? I think one, just amazing project that I've seen, the program in TB has been releasing an application specifically for citizenry, TB Arogia Sati, which is for citizens to find out about their symptoms, to find health facilities, for patients who are under treatment to understand when is their next refill due, when is the government benefits coming to me, what is my adherence. And while that still only addresses smartphone users, that number is increasing. So I think more innovations and more thought around going directly to the patient. Of course, we want tools that empower healthcare workers and doctors themselves, but the more we can kind of reach directly to patients or end beneficiaries, I think that'll really help the conversation move ahead.
Yeah, and maybe, I was thinking about this a few weeks ago, and I said maybe it took a pandemic to put us all on one electronic platform, which is COVID. So, technically the journey to the patient health record has started. And I'm presuming everybody on this panel actually has already registered on that app if you're vaccinated, and I'm presuming all of you are. So maybe we're already in that direction, Andrew. So let's see how we go forward. I'm gonna change my sequence a little bit, and I'm gonna go to Deb first, and then come to you, Kamini. Deb, proactive remote support. How is that going to change? Because that's something we've seen a need for, and especially during the pandemic, I think there has been a lot of conversation. Why don't you shed some light on that?
It's a great question, actually. So you have to keep in mind the large geographical landscape of our country. And whenever you talk about the key elements of testing, we must remember that it should be fast, easy, accurate, and should have the potential to go for the last mile testing, right? With minimum hands on time. So if you keep everything together holistically, so you'll understand that this is proactive remote support forms the backbone of testing at the national level, and definitely it should be the backbone of success for any program in the country. The government is doing fantastic work in this regard, and definitely, this becomes the core pillar of any program, be it for, I think this can, this can open new horizons, maybe in the form of a decentralization with the disease surveillance. Dr. Kamini is doing fantastic work in the AMR surveillance. So ease of use. So each and every aspect of this, digitization can actually contribute to this remote support. And these two are completely integrated. And so we must not forget that. And at the same time, the maximum uptime of the testing solutions is possible through this remote support. So yes, definitely when you consider some local support, definitely in terms of manufacturing and others. So this is completely integrated for a true way forward.
Great, thank you. Thanks, Deb. That's a very important point you just made, and I think we are going in that direction. Kept the last question for you, Kamini, which is really about integrated diagnostics. And that's an area which is going to be absolutely critical, especially in the work that you're doing around antimicrobial resistance. So how are we going to integrate it? How is that going to help us achieve surveillance for AMR? Even now you've got Nikshay, you've got Coven, you've got multiple such verticals. So some thoughts on that, Kamini, because if this comes together, it's definitely going to help your work.
So definitely a very important question, because having multiple apps and going on to the multiple apps is going to create more challenges for us. The way we are facing an AMR network now, we have a vertical for capturing surveillance data, we have a vertical for capturing hospital-acquired infections, and we have another vertical for capturing the antimicrobial consumption data. Just imagine the same program being funded by ICMR, but over a period of time, we end up developing three separate programs, and now we are struggling with how to create a convergence for them. So this is within one organization, and you forget when it is the verticals between the different programs, that it is a TB program and a leprosy program and another program. So I think, a lot is being thought about and discussed about as well. And it's not that we are operating from a space where we are completely uninformed of these challenges. We very well know from the history that, what all can come forth and what all we might face in future. So as government is actually planning to strengthen the diagnostics aspect, whether it is through a free diagnostic initiative or having this ID blocks, the infectious disease blocks in the district hospitals, there is a intention to strengthen the diagnostic space. That I think is a very good opportunity to also improve the IT and the data management systems as we and give it equal importance as we give to improving the labs or improving the availability of X-rays or equipments related to diagnostics. I think because otherwise we will not be able to utilize the investments we make in diagnostics for improving public health or for the patient treatment unless we give a lot of importance to that. And of course, there is when you have a well structured IT system which allows you to bring out the guidelines, bring out all the directions, as we have seen with the COVID. I mean, everything was circulated in a real time manner and everyone got that information. I think that's a very good resource for creating education as well as awareness, whether it is about tuberculosis or whether about AMR or non communicable diseases. So I think the next era should be of strengthening the systems that reduces inequity in the health system and reduces the divide that currently prevails.
Fantastic, Amini. And as a lot of people have said, from a we've of course COVID has taken a toll on all of us, but from a public health perspective, we've kind of seen a lot of positive change. We've seen what we can do if we really put our minds to it. So hopefully this momentum will continue. Hopefully we will continue to build on this and take this forward. I think you've been a fantastic panel. Thank you so much for joining me today in this conversation. And I really look forward to catch up with you in person very soon. Thanks a lot.
Thanks, Neeraj and panelists. Let us now hear a sum up from Rashi Garg to complete the learnings from this panel.
Thank you to all the panelists for a great discussion. Very, very engaging last 35-40 minutes. And something that we learned, and we learned a lot in the last 35-40 minutes. I think to sum it up, it's very clear. The need is to shorten the time to result in better quality and fast reporting multiplexing capabilities so that we are able to provide more information to our clinicians, to our healthcare providers in a very, very less time. The second, I would say, when we talk about connectivity, digitization, and there was a lot of discussion around that, unidirectional automated solutions will become important, especially when we talk about decentralization. We will see that we will require technologies that require less skilled manpower dependency. Testing solutions which provide quality report that are connected to decentralized diagnostics will really provide an ideal pathway for addressing various disease states that we see in India. What I'd also like to share with everybody is I'm very, very proud to share that, in Cepheid, we have taken a step ahead to work with the government of India on the localization, on expanding the localization footprint in the country. It's a huge stride in support of government of India's TB eradication drive by 2025. And Cepheid is committed towards that vision. We want to strengthen the Make in India commitment that the country is showing by enabling the Atmanirbhar Bharat with better digitized and connected solutions. Thank you everyone for your time, and thank you to the panelists again for their great insights.
Thanks for the message, Rashi. It was very succinct and focused. Moving on to our next panel for the day on healthcare cloud, benefits, compliance, and possibilities. When it comes to healthcare, cloud computing technology can be effectively applied to overcome two major industry challenges: increasing cost effectiveness and building a self sufficient health ecosystem. However, exploring caution points is equally important. Here are our panelists: Dr. Sujoy Kar, Chief Medical Information Officer and Vice President, Apollo Hospitals; Arun Goyal, CIO, Sir Gangaram Hospital; Sunil Kumar, Deputy Director General, National Informatics Centre, Government of India; and our moderator, Jaspreet Singh, Partner and National Leader, Client and Markets, Trust and Transformation, Grant Thomson Bharat LLP.
Cloud computing is one of the leading trends in digital transformation for 2021. We've already seen leading tech companies been offering this technology increased usage of online tools in the entire pandemic scene. In fact, I was reading a quotation somewhere which said that 65% of routine surgeries in the United States of America are being performed by robots. And believe me, that's a very scary percentage, right? I wouldn't be on an operating table with a robo knelt over me, and something happens to the cloud infrastructure. I think rapid times. Once a week we do board meetings, right? We walk into board as advisors. 3-4 years ago, there was a lot of apprehension on what does healthcare and cloud have to do in common. Now more and more hospitals, medical organizations we meet, including the government, the question is, what does it take for us to now move to the cloud, and how soon can we move to the cloud, right? So there's been a radical shift, and obviously the entire pandemic in the last 18 months has also been responsible for this entire digital transformation from an on-prem model to the entire uh, cloud model, right? Given the pandemic crisis, cloud computing is specifically made data destination that cuts storage and serves as enterprise transformation platform. When it comes to healthcare, the technology is applied to overcome two most, I think, according to me, and then we'll like to hear my esteemed panelists talk about them more. Two more industry challenges. One is the entire cost effectiveness, and second, how do you build a self-sufficient healthcare system now that we, I think, as a country are trying to answer from a very very long time. So let me start by coming to you, Sujoy, since you are the first in my frame. Very welcome to this esteemed conference. When you got an invite, what were your first thoughts on this?
Thank you, Jaspreet, for the kind introduction. When I first got the invite, I thought I would be speaking on more on AI, but then I was told that AI we will keep it for some time. We will talk about the cloud-based healthcare, and in so many ways, particularly in clinical terms, that we see the cloud-based healthcare evolving into a space of what we call as collaborative and connected healthcare. Even if we do not go through the analogy of doing 65% of our surgery through robotics, we can start it with where secured, meaningful, longitudinal patient data are promising to provide, number one, ethically sourced, accurate data which are helpful in getting unbiased, inclusive, and fair insights, number one. Number two, augment the process of technology in healthcare with better adoption and workflow integration. And then at some point, understand the care processes perspective that what would work and what would not work in cloud setting. And you gave an example of robotics there. And third, and the most important, is to bring the element of trust in the ecosystem concerning patients' data with a collaborative approach to improve their health and focus on wellness. And we're seeing this over and over on different digital health platforms where we are getting patients' data on a real-time basis. So what do we do at Apollo Hospitals? At Apollo Hospitals, we have been using cloud storage for some time now in different forms. So the first activity is to source the data, multimodal, high velocity, high variability data. High variable in these terms means you are not just collecting EMR or lab values, but you are also collecting PACS images, videos, and others, all this multimodal, highly variable data, and put them into the cloud in a way that they are scalable from the different insights that you get into that. Then the next is about ingesting them in an ethically to look at it, what we typically call as an EATL mode, where we are extracting, anonymizing, transforming, and loading the data. But most important component of all of these activities is to harmonize this data and provide what we call as their provenance, where is the source, and codify them, and then to use their lineage as to how they flow over a period of time. And finally, we enrich it by building AI/ML models, which would look into the longitudinal patient records and say, what are the risks of developing something or giving recommendation or causality at some point. When you have built this model, then the power of your cloud actually comes most befitting at that time. Because in modern day, nobody in the world would go about in sharing their data. So now you have a system of federated learning where you are able to take your APIs into a cloud container in different institutions or in different countries, and they can call their APIs and validate your AI models in that way. And it is not just about validating AI models. It can be used in other APIs, chatbots, third-party applications, or even business intelligence. So to conclude, for organizations who are getting into, the entire cloud-based healthcare transformation, I would suggest that they have 5 or 6 steps to look at. look at your operational backbone as to how you would do that in a most seamless way without compromising on your patient care. What is your strategic priority to provide shared patient or provider insights? What is that you are going to deliver in form of clinical platform? How multi-sided it is, how you are bringing in the patient's perspective, how you are bringing in different doctors' perspective, and making them to communicate with each other. Getting into an accountability framework where you are looking at data privacy, confidentiality, and security in a very, at the very beginning of your discussions on that. How do you involve your third-party developer platforms to come and integrate? And then make a choice between whether you are going to do it yourself or whether you are going to do it with some partners, what we call as modularity versus interdependence. There are my initial thoughts.
I think very well said, Sujay. I think if I were to pick up 4-5 key points, you spoke about accountability, you spoke about interoperability. I think one of the areas where I feel a lot of lack of comfort today is the around the entire privacy security of data. And then the last point that you mentioned also resonated, I think will resonate very well with the audience on whether do you do it yourself, do you do it get somebody else to do it, and not only look at yourself, but you mentioned third parties, right? Third parties, vendors, look at your entire ecosystem, because they are going to play a very key role. Let me come to you, Mr. Sunil. I think we have a perspective from somebody in probably one of the largest private hospitals, right? Coming from a government perspective, where cloud is, as I understand, one of the biggest with one of government is spending one of the biggest money in getting cloud enabled to do all its services. What would be your initial thoughts?
Thank you, Jaspreet. I think let me start with a little background. We have a product called e-hospital HMIS, Hospital Management Information System. So NIC started developing this in 2007, and all our installation in almost all the 50 big government hospitals, they were on-premise servers were there, and it was very difficult to replicate such solutions across India in all the hospitals. So government gave a deep thought on this, and in 2015, when this government came, they basically give focus on cloud computing. So once that thought came into mind, though, so we migrated our application from on-premise to cloud-based application, meaning thereby, so you have to have onboarding of hospital rather than installing the hardware in the respective hospitals. You have to have a soft piece of software as a service on cloud, so that you just onboard on it and start using it. So it changed the scenario. So we more and more focused on basically on the training of the doctors, of the operational staff, rather than managing the infrastructure in the hospital. So as on today, we have 500, starting with 2017, in last 4 years, and we basically onboarded 500 hospitals, and they are live, and they are utilizing this basically software, HMIS software. And apart from this, we have, after any software which is developed after 2014 or say 2010, I should say, after that, all the applications are primarily on cloud technologies. We have basically CGHS software, Central Government Health Scheme software, which is operational in all the CGHS dispensaries. It is more than 400 CGHS dispensaries. It is on the cloud. So we just, if any dispensary come up, so we just onboard it, and they start. They have to arrange two things only. One, they have to arrange PC and the internet connectivity, and the operation in that hospital starts. So that is the first thing. And while doing this exercise, I think we have come across certain experiences. I would like to share those experiences. So we are talking, when we talk about health cloud, so it means we are talking of infrastructure on which these applications ride. So it has primarily three components. One is basically you have to have a secure health network. So cloud has no meaning until unless you have a network. So you have to have secure health network. Second is basically health cloud itself. And the third one is basically, which is more important, is security and privacy operations. So these are the three primarily component on which government give a focus. So
Sure.
NIC has its own cloud called Meghraj with the help of Mighty, and we host all our application on this cloud. It is not a health cloud. Government is giving focus on creating a health cloud, separate cloud for health sector. And there are multiple reasons for that. It involves a huge data and huge processing power is required, and secure network, especially if you want to go in for transmission of images, videos, and radiological reports and say images. If they need to be transmitted to provide the telemedicine services across India, so you need separate secure health network. You need separate health cloud and security and privacy operations, keeping basically consistent monitoring you need for in terms of security of the data and privacy. And one of the prime concern is consent management. So we government give a focus that patient is the owner of the data. If patient is the owner of the data, so sharing that information in a secure manner from one doctor, one hospital to another, one doctor to another, or one party to another party, consent of the patient is very important. So for that you need infrastructure. Without that kind of infrastructure, these information, these consent cannot be managed. Apart from this, as you know, we are answerable to the parliament, to the auditors, to the so some sort of auditing is to be done for this infrastructure. Comprehensive. Say there is a practice in NIC to have a comprehensive security audit of every application, especially application related to health, because we have to have a security audit of network. If you encrypt the data, so performance degrade. So you have to make sure that network speed is quite high, that it can transmit the data in a secure manner effectively. And if some of the application they are running on premise, then we have to redesign the application and to move it on to the cloud. So that these are the 5 steps I think that need to be considered for as far as infrastructure for hosting the health application. And I think one more important point that you mentioned for this robotic and other things in government sector, especially in aims, which are so for that, I think government is thinking of have a separate secure health network, so that which is a high speed network and separated from the other applications. Only then this is possible. Thank you very much.
So, sir, I think for initial talk, I think it was probably one of the most comprehensive that I've ever heard in my last 5-6 years of moderating these panel discussions. And I think you made some excellent points. I was not aware of NIC starting the journey from 2007, and you having local hospital management systems to now everything being on cloud, and you just do plug and play. Two, you spoke about, I think, the biggest issue that everybody talks about from a healthcare perspective is scalability and the entire consent management piece, right? With our personal data protection bill just around the corner. How does how does hospital manage consent? How does it pass on to other intermediaries. I think it's going to be very, very interesting space that will be keenly watched by a lot of people. Over to you, Arun. Your initial thoughts, please.
Thank you, Jaspreet. I'm happy I heard Sujoy and Sunil both, and this both of them's views goes along with the NDHM architecture, which recently government has announced. I was fortunate that I was project director with NDHM before this assignment, and when Prime Minister inaugurated the NDHM in the name of ABDM. So that particular architecture we prepared, the whole NDHM architecture in NHA, and it goes with the privacy by design, security by design, voluntary participation, patient consent, the security aspect, all those aspects, and which Sujoy and Sunil has mentioned here. So that is obvious when government is coming up with the framework which is conceived on the federated architecture across the country and consent-based healthcare system, which we conceived after evaluating 5 countries' healthcare system. So 5 countries' health best practices which we evaluated were Canada, US, UK, Singapore, and Australia. So these 3 countries' healthcare systems were evaluated and best practices have been analyzed. These are available on the NHA's website. Anybody can go there and see it. So I know, as Sunil has mentioned about the interoperability among the hospitals, now in the coming years, we need to come up and think through about the health exchanges. So now the major part which has not been talked about and missed was health exchanges. So all the data which will be there among all the hospital and the service providers will be transferred through the health exchanges, obviously through the consent management. And consent management, as Sunil mentioned, the patient consent will be managed through the health ID cards. The health ID card will be provided to the health facilities. And based upon that, health facility will trigger that consent to the central server, and central server will provide the OTP. And that OTP will be provided to the facility, and based upon that OTP's transaction, the transaction will initiate, and the data will be fetched from the service provider sitting across. Suppose if somebody is in somebody visited in the facility or hospital in Bombay, and now he is visiting in Delhi, so he should provide the card to the Delhi hospital, and that information will go to the NHA server, and then it will go to the Aadhaar server, and then OTP will be given to the patient, and that OTP will be provided to the hospital. And based upon that, NHA will fetch the information from the Bombay location server. In this, the beauty here is that data will be residing with the health information service provider only. Data will not be consolidated, and government will not be owning the data per se. The data will be residing with the health facilities, and ownership is residing with the patient. So patient will decide whether his data can be used for transfer purpose, or the data can be used for analytics purpose. We have provisioned into the NDHM that data which can be used by the government for the research and analytics purpose will be anonymized. So, patient's privacy, even for the research and analytics purpose, gets protected. And so far as the security is concerned, security is also been mentioned. We have mentioned the protocol which needs to be followed up by the respective information service providers while transferring the data and keeping the data at rest for the security purpose. That has already been defined there. But yes, as Sunil has mentioned about the e-hospital thing, so similarly, people in the corporate world is also moving into the cloud, and they are dependent on the cloud. In I'm managing the Gangaram. Gangaram, we also have our HIS and all the systems available on the cloud. And in previous assignment at one of the hospital chain in Bangalore, I was managing 28 hospitals, HCG hospital, where we managed all the hospitals by publishing HIS on the cloud. Or that there was a single instance available on the cloud, and all hospitals were on the same application, and we were exchanging the information among all the hospitals. Furthermore, HCG being an oncology chain, we manage the cyber knife also, which Sujoy was mentioning about the robotics, etc. By creating a hybrid model so that these surgeries, etc., doesn't get impacted in case of an eventuality of no network availability. So we manage the servers locally as well as at the later stage, the nuclear physics and the cyber program and protocols can get synced with cloud at the later stage. So that type of arrangement needs to be managed while publishing and using the cloud services into the healthcare system. So I understand the sensitivity into the surgery and the all the sensitivity when you are dealing with the patient, be it into the ICU or in the radiology, etc. You need to create a hybrid system out there while publishing your or using the cloud services and cloud application. So you have to have on-prem servers also that gets synced into the cloud at later stage. So that is my take initially on the cloud
Wow.
services.
I think, again, quite comprehensively covered, right from NDHM to cloud to your personal journey to what's Gangaram doing today in terms of cloud, and also the AI robotics piece. So I think, Arun, I'll now start with you. Right, you've seen probably both sides of the coin. You've seen traditional healthcare, and now you're seeing the entire extended ecosystem of cloud healthcare system. What, according to you, could be the difference between both of them?
So see, a major challenge in the cloud-based application comes in when as Sunil was mentioning about the scalability and the you need to make sure in business, if you are into the corporate business, you need to make sure first thing which you need to make sure is the business continuity plan. So in the event of any pandemic or any pressure, wherein the network, there is a pressure on the network, you need to make sure that your data or the services doesn't get impacted because of the network. Because your data at the end of the day, if it is sitting on the cloud, you need to make sure that all things are sitting and services are not getting impacted. Be it registration, be it discharges, be it reporting, be it any invoicing, etc. into the hospital. All these services when there is a load, there is a patient coming into the hospital for the services, these services can get impacted if bandwidth or the cloud services get impacted because of the network availability or otherwise. So those things you need to make sure that how you are managing it, whether you are increasing the bandwidth, you are keeping the standby plan for another service provider, or you are managing it by hybrid solution where you have a local data center which is getting synced to the cloud at the later stage when network available. So you have to prepare for all these type of eventuality when you are dependent on the cloud services. So that is a first thing which I take care into the corporate environment where you need to make sure that patient is first while designing anything or any strategy. So you should keep patient on the top of your mind while creating the services.
I think excellent point from a patient perspective that we need to know who our end user is, and how do we keep his interests at the forefront.
I would rather add that while designing a IT healthcare strategy, particularly in the corporate environment, you should keep four things in mind. The first, as I told you, the patient first. So all the services where you are touching the patient, be it appointment, discharges, their report delivery, their follow-ups happening, how they are managing whether after discharge, whether they are following up the all prescription and consultations properly, their physio is happening, everything. So those are the touch points which you need to take care when patient are there into the hospital. Another thing is the clinical decision support system. Whether as Sujay was mentioning about the AI and BI, we need to make all efforts that how we can include the clinical decision support system into the HIS and your EMR EHRs, so that clinicians gets benefited out of it while consulting to the patient. So that is a clinical part. How we can improve our clinical care to the patient. Aspect is the management piece where your aspects.
Sorry, Arun, we lost you on the management piece, but I guess I think you were talking about how do you manage the entire piece. Thanks for this comment, Dr. Sujoy. I'm sorry. First, I did not realize you were a doctor, so I couldn't salute you like that. So uh, you know, Dr. Arun alluded to some points around uh, enterprises preparing strategy. You are in an enterprise, one of the most renowned enterprises hospitals in the country. What would you advise? Because lots and lots of hospitals still follow the on-prem model, right? And if I'm an hospital CIO, CISO hearing this conference today, how can an enterprise prepare for a cloud health strategy, if I were to put it that way?
Right. Thank you. I would like Mr. Arun to pitch in, on the points that I'm going to make. If you were looking at, how do you enterprise prepare for a cloud health strategy? The first point is about what are your priorities? What are that you are looking at in terms of whether you are seeing it from a consumer-friendly patient experience, whether you are connecting your physicians and your referral management, or you are looking at an intelligent patient outreach, which we are seeing in a lot of connected device or digital health platforms and all of that. And do not forget that there are many ways that we are now looking into continuous monitoring at the patient home with all the medical IoT that are coming into that. When it comes to your migrating to your cloud, it is important that you choose your vendor, you go through the transformation journey, accelerate and agility, but most importantly, here again, empower your team, empower your local team to actually make the decisions, to actually see what they can do to facilitate this change. And I've seen this happen within organizations, public or private, anywhere in the world. This particular transient shift from a clinicians to get into legacy systems to transform into cloud-based healthcare system takes a little bit of time. So the more you engage them early, the better it is. And as I said in my opening remark, you would still need to look at your operational backbone in all of these so that you can still continue with your seamless care, looking into what kind of insights that you can give it, and then bring in people on board.
Perfect. I think very, very valid points. And since I just take a cue from that, and Mr. Sunil, you mentioned, if I remember correctly, sorry, you mentioned about data anonymization, right? And then making data available for other people to do their research, to do their analytics, right? Uh, so let's probably elaborate on this for next 2-3 minutes. What other safeguards and protocols do you think the government should apply to the data in cloud? And from a security privacy perspective, should the patients out there who are listening to this conference, people like me, and everybody else, right, be worried about what's happening to their data?
I think Dr. Arun has very clearly mentioned that on ABDM website, data sharing policy, data privacy policies, these are available. So what I am saying is, when we share the data, suppose I give an example, audit department has asked me to share the data, patient-wise data, with them, audit department. So we said we can share the data, but we will anonymize it. Reason
nice.
we cannot give you, and anonymization is to be done in such a way that you cannot correlate in the backward manner. So if you can correlate, like if you remove name, age, sex, mobile number, and personal information of the mobile, even if you remove this, and if you don't remove CGHS ID, so there is a possibility that you can correlate it. So this is where the anonymization. So there has to be a clear, lot of thought process has to go into this. So every data set we have to understand the data set and how that anonymization will take place and how it cannot be back correlated. I think that is very important. I think Dr. Arun has to.
Yes, Dr. Arun, please.
Yes, sir. I just wanted to add into your statement, Sunil. in the anonymization, as he rightly said, that we need to make sure, as per the policy, etc. First thing is the technical anonymization. The anonymization itself has been challenged technically, that it can be de-anonymized. So there are protocols. We need to make sure that it is anonymized in a fashion that it cannot be de-anonymized. That's the first technical thing. Second thing, we need to make sure at a different level of the information that how to anonymize and what to anonymize. See, there are information of the patient. I'll just give you one example. See, if Sujoy is coming from the Apollo, and Apollo has got now they have established the proton therapy in Chennai. So proton therapy is happening only in the Chennai. If you have an information of a patient got treated in the oncology with the proton therapy, you remove every information and leave it the proton therapy related patient. Anybody will make out that this patient is from the Chennai, and it is not difficult to find out that who was the patient. Right? So you need to make sure that what type of information is getting shared. So what type of level of information needs to be anonymized. Even the procedures needs to be anonymized at times, so that you are I get you, Sujay, you got a lead now. So so that way you need to make sure the level of the information, what type of information need to be shared. Based upon that, your anonymization rules need to be framed. So Sunil has rightly mentioned. I would hand over to Sujoy. He has something to say. Sujoy.
And that is where the technology is moving these days. If you look at today, what organizations like Microsoft or Google are doing, and we work very closely with them. The interesting thing is, once you begin to anonymize or even go a further step and encrypt that data, there are now standard methods to actually run analytics on the encrypted data and get the results. So you would not require to decrypt the data or de-anonymize the data to actually run anonymization. Those kind of technologies are only based on cloud at the moment, on cloud computing. You cannot possibly have an in-house server and run those again. So that is called homomorphic encryption. And then there is a second one where we are looking at more and more thought processes going into this, which we call as differential privacy, where we are able to withhold the patient's PHI. What we call if you look at HIPAA guideline today, there are 21 PHIs, health information, private health information that the individual has. You would have to see that all of these 21 PHIs are eliminated. What Mr. Arun was saying, or Dr. Arun was saying, that you have to eliminate so that in any ways of traceability, you are not going and leading to that patient. That is very, very important. But yes, there are technology available at the moment or are evolving in the space, which will help in even working on encrypted data.
So NIC has launched basically encryption as a service.
Yes.
So yes, you send your data set and encrypts, and you can store it at your place. So it doesn't store anything. It gives you encrypted. And if you want to decrypt it, you have to go back to that service. So that the encryption and decryption as a service are available. So we have been transmitting the sensitive data over the network using encryption.
And one of the beauty about that encryption system is this, that you can anonymize also on images, where you have certain remarks on the images, as you would see, which are typically a PACS vendor would keep. They will have all of those patient details, UHID, age, gender, and all of that. So you take it to at that level where you are able to encrypt that as well.
Yes, I fully agree. We are working on AI model for basically a TB patient. So if you submit the chest X-ray, and it will give you do you have probable TB or what kind of TB. So that kind of modeling we are doing. I think this is where we first apply anonymization, because the creation of the training set. Say you should have basically X-rays of the TB patient, and we anonymize the data first, and we don't know. We are getting the X-ray. To which patient this X-ray belong is not known to us. So we got about 60,000 such X-rays. So first anonymization was done, and then it was taken into the AI model for as a training data. So it is a practice within the health, because in the health sector, research has to happen. So for the research, you need some data, and for giving the data to the researcher, you have to have an anonymization. So it's a natural need for this.
I would like to add here, sir. Just want to pitch into it, because we are talking about the anonymization of the data, and because I was associated with the DHM framework and creation of the policies, so there are exceptions also in the anonymization. So in clinical practices, what happens? There are critical cases which needs to be analyzed unanonymized. So in those critical cases, there is a provision of taking the patient consent for to analyze non-anonymized data as well.
I think super points around the entire anonymization piece. I think everybody listening in would know how to design their entire HIA systems, and with deep insights from Dr. Sujay, Dr. Arun, Mr. Sunil. I think they will go back richer in terms of the entire cloud strategy. I've been getting messages from the organizations to wrap this up. So any closing comments in about a minute each? Start with you, Sunil, go to Arun, and then Dr. Sujay. So, Sunil, any closing comments, please?
My only request is that health is data is very sensitive. We should secure it, and privacy policies has to be, and compliance has to be there. And if you want to go ahead in a digital world and providing taking consent is one thing, but transmitting the data from the source to the patient and then to the other party, I think this is where we have to be very cautious.
So while creating the strategy for the healthcare and having the systems on the cloud, you need to make sure. Obviously, the security should be always there and keeping the privacy of the healthcare data. But I would request to create a standby systems also while taking your systems to the cloud, so that your clinical practice doesn't get hampered in a critical situation when you don't have an internet connectivity out there. So BCP should be kept into the mind.
Oh, we'll discuss that probably in our next conference. Dr. Sujay.
Yeah, I mean, very, very nice points from Sunil sir and Dr. Arun. I would say a little different from technology, and I would put it on the people, the security culture that you would like to have, or culture of security that you would like to have in an organization who are going through this transformation. First of all, you would have to bring about a balance between technology, training, people, and process. A lot of importance has to be given on focus on the individual behavior about security around how we are using patient-related data. Stay updated, particularly with things that are coming out in technology in terms of multi-factor authentication or zero trust. And I think if you look today at the document that comes out from the government, whether it is National Health Stack or NDHM and all of them, they're fabulous, very, very well thought-provoked document where people have contributed and built that. So from a structural perspective, in country, we have a very nice way or a policy to lay out how this has to be done. But then the most important thing is how do we go about implementing it and getting the maximum leverage out of it.
Superb. I think, esteemed panelists, it was really a great session moderating this esteemed panel with you. I would once again like to thank the entire Financial Express team and wish them all the best for the FE Digital Health Conclave 2021. Thank you.
Thank you, Mr. Jaspreet and the panelists for your views. Before we proceed, playing a short video from our sponsor, Cloudera.
Have you ever wondered how we sequence the human genome or how we'll send humans to Mars? Well, at Cloudera, we believe that data can make what is impossible today possible tomorrow. cloud era.
And before we move ahead, thanking our partners, presenting partner Optum Global Solutions India Private Limited, powered by ICA Care, co-powered by Navya Life Care, technology partner Cloudera, supporting partner Acnamed, and associate partner Kefeed. Moving on to our next panel discussion now, digital need, hospital supply chain as a focal point.
Good evening, everyone. Hi, good evening, Saurabh. Yes. Can everyone hear me?
Yep. Saurabh, am I audible?
Thank you. Yes, you are. I think it's very
Saurav, your voice is not coming through very clearly, at least for me.
Yeah, it's patchy, Saurabh. Can you try again?
Yeah, is it better now?
Yeah, it's coming now.
Yeah.
Must be a patch. Madan, do we have you as well?
Yes, can you hear me now?
Yeah. I think we're good to start. Nikita, Nikhil.
We can, I think, begin with the panel discussion now.
Sure. Thank you, everyone. Thanks, everyone, for joining. Good viewers, welcome to the session on digital health, digital need, hospital supply chain as a focal point. We'll come back on why we chose this as a topic, but a quick round of discussion, introduction to everyone. I'm Saurabh Pandey. I'm the founder and CEO for Acna Medical Private Limited. I come with almost 16 years of healthcare experience, a good bit of being a consultant, then an operator, and now as an entrepreneur. At Acnamed, we're trying to build a platform for hospital literacy. We'll talk more about it. Supply chain is clearly a focus area for us as a business and as professionals, and hence we chose a topic which is quite relevant post-COVID. And I'm experienced institution heavy group to discuss. I'll do a quick introduction to everyone and then give the panel forward with individual sessions for each panel.
Saurav, unfortunately, your voice is not coming through very clearly. I don't know whether you have the option of getting onto an alternate network, but it's not coming through clearly at all.
Is it for everyone?
Yeah, I have the same problem, Saurav.
1 second, just 1 minute. Is it better now?
Moments.
I'll carry it forward. I think it should be better now. Yeah. So I'll move forward with the introduction. So I have a strong team of panel members with me. I have Mr. Srivatsan from Intent Health. Srivatsan sir is a veteran in the space and has spent considerable time, I think more than any one of us, talking about technology adoption by healthcare stakeholders. It will be great to hear his views on what has moved the needle on technology in healthcare space. I also have Mr. Madan Sampath, who is the group head SCM for Healthcare Global. Madan brings on board a very unique international supply chain experience, also from a non-healthcare setup, and it will be good to hear him discuss his experience of leading healthcare supply chain function in some of the leading hospital chains in India. I also have Sumit from Cipla. Sumit heads the digital transformation and commercial innovation at Cipla. It will be good to hear Sumit talk about OEM perspective in the changing healthcare ecosystem, special focus to the hospital supply chain, and his own dealing with various channels as he has approached digital transformation from OEM perspective. We have Kaustav Ganguly from Alvars and Marshall. Kaustav is MD with A&M Healthcare Practice of India, and he's been working actively with some of the healthcare businesses on transformation work. We'll talk more about it during the panel. And I also have Kaivan, who's the India Healthcare Partner for EY, probably the most known face of a hospital supply chain consulting work in hospital. He started talking healthcare supply chain long way back. It will be interesting to see what he has concluded as his views of what has transpired over the last few years. To start with, I think the topic which we are talking about is digital need, hospital supply chain as a focus point. I will like to divide this into two specific data sets or two specific focal points. One, the use of technology in hospital, and probably second, the use of supply chain as a strategic tool, and how both technology and supply chain need to be married together to drive some of the digital work or transformation work which hospitals wants to do, to drive efficiency, to drive procurement benefits, and also to bring down cost, especially in the times when COVID did teach us a lot of shortages and material issues as we were trying to service a much larger number of population. I'll request each of the panel members to start with a brief introduction and respond to specific questions, which I will probably ask them to. Your response can be anything from 3 to 4 minutes, and then we can all open up into a open discussion and then try to conclude the session. We don't have much time, but let's try to engage and take this forward. I'll start with Srivatsan sir, if that's fine with you. You have probably seen technology and healthcare from 2005, right from your IBM and healthcare ways. You have seen how hospital at least aspire to use technology. Wanted to bring your perspective of what you feel has changed over the years, and how do you see now probably the time is right to hospital to become digitally savvy or digitally first. So over to you, Srivatsan sir.
Thanks, Saurav, first of all, for including me in this panel. And fortunate that you're saying I've been at it only from 2005, and I've been at it a lot longer. So I started this whole thing about technology solutions for hospitals way back in the early 90s. We built an appointment scheduling system for a hospital, really in the early 90s. There, I was actually also involved in the rollout of the initial HIS systems in the country. Most of the initial HIS solutions were built ground up by the hospitals, and I was part of some of those initiatives. I was at that time involved in building hospitals. Right? Many years that I spent setting up hospitals, and I always felt that technology was going to be an important component. So then I took an active role. That's when I went to IBM, when I actually started helping hospitals actively implement technology. Since 2011, I've actually been co-founder of a large TPA, where again we are on the other side from the hospitals, and we've been encouraging hospitals to use technology in different ways. But what I'm seeing is that while there's a lot of traction on the way that consumers are using technologies to interact with healthcare providers, the hospital's own use of technology still remains a mixed bag. There are areas where we see hospitals doing a reasonably good job. For instance, we recently did some work for a small not-for-profit hospital, and we found they had a very good HIS system. Their data capture was very good. But the problem was, what did they do with that? So therefore, what my take is that while technology adoption has obviously improved over the last few decades, hospitals are not yet there when it comes to using technology effectively. So yesterday I was talking to somebody and he actually coined this term. He said hospitals are still hung up on hospital information systems, whereas they should have moved to hospital intelligence systems. So there's a lot of data that is being captured, but the insights that hospital administrators are able to pull out of that is obviously a challenge. Part of this, I think, has to do with the fact that when you look at Indian hospitals, I mean, obviously there are several thousands of them. At one end, we have the really large, the Apollo, the Manipal, all the corporate hospital groups, which clearly have an excellent roadmap. They're doing great work as far as technology adoption is concerned. But then we have a large number of the sub 50 bed hospitals where there is quite a struggle because the owner, who's often a physician, has to try and do all of this on his or her own. They have to grapple with the complexities of technology, the costs of implementing technology, right? And therefore, I would have to say that technology adoption in hospitals is at best a mixed bag, right? And if there are specific questions at some point, I'm happy to answer that when we get to that.
I think thanks for that introduction. I'll probably use that as a cue and move to Madan. Madan, of course, brings the hospital perspective as a panel member. Madan, I think what Shivasan sir was saying that there is an intent, there is a lot of data, but using or making sense of data is still something to be worked on, right? With that context, will be good to have your views on what you see focus area, especially for supply chain as a tool, and given that supply chain is a starting point of a lot of data generation for hospital, right? You have seen that, so will be good to have your views on supply chain as a strategic focus and how hospitals are looking at using this data.
Thanks, Saurabh. Thank you, Financial Express, for having me in this panel. A big hi to all the panel members, and a special hi to Kaiwan. I've been knowing him for quite some time now. See the most important when it comes to supply chain, I don't know if I had to thank COVID or not, but yeah, there has been a special focus on healthcare supply chain, especially over the last 2 years. So like Saurabh mentioned, I've been predominantly in the manufacturing and automobile industry for the first 15 years of my career, mostly outside India, where the main focus are into the processes and tools, right, when it comes to procurement or supply chain, right? The reason why I moved into healthcare is to not to reinvent anything, at least establish a process that the industry can handle over the period of time. Because healthcare is something in India which has a major scope for increasing its overall turnover. So when you don't have the adequate process and methodologies to manage it, it's going to be very hard for all the hospital chains to live up with the current tools what they have. So mainly the changing expectations, right, of patients as customers and the highly regulated nature of healthcare, it's kind of creating a unique challenge and driving change today. Right? So at the heart of these changes is the supply chain management today, with its I would say the strategic role within the affordability and quality of the patient care. So as well as in the cost structure of the healthcare organizations. So when when we look at it, supply chain management cost. So every time we look into the P&L consistently, it ranks as some of the largest expense for any healthcare or hospital systems, right? So there is a new way of looking at the P&L or the revenue statement these days, where your material cost significantly adds value to your both your revenue and to your EBITDA. So it has become evident that productivity improvements and the healthcare supply chain cost reductions are the top priorities now, not only in India, across the globe. While there are need to reduce the cost, there is a need for expansion, there is a need for service excellence, clinical excellence, and so on. So how do we do to strategize it? So it's more of pay for value model these days for the patients than how it used to be the traditional pay for service, right? Where the cost of care was often paid upfront. More healthcare leaders today are looking at how they can provide an improved patient experience, right, while running its cost. So this is something where, like Mr. Stevenson clearly mentioned, the data points, the more holistic end-to-end approach to the healthcare supply chain. It's not just about improving the efficiency and reducing its cost but to the hospital, but I would say it's rather about providing better healthcare in the least lead time and to lower cost to the patient. So, so supply chain requires those flow through a consistent process and are inclusive of the clinical quality and outcome. So that's how I look at how we have to redefine the strategy for supply chain. So
Sure. So thanks, Madan. I'll probably come back to you and dig deeper on some of the stakeholders internally of that supply chain function, given that consumer or patient in this case is a clear beneficiary and he has a cost advantage. But some of the internal stakeholders like a paramedical or doctor has their own challenges for adoption of technology on, especially from a supply chain or internal HRS perspective. So we'll dig deeper, but I'll want to just move to Sumit. And Sumit, it will be good to have a minute of your introduction, your background experience, and then want to get your views of how do you guys, given that you are probably one of the leaders in the OEM pharmacy space, you have seen the disruption that COVID brought to the table because of shortage, and how difficult it was to make the product reach, at the same time manage the demand supply gap, right? In that context, how do you see supply chain or digital supply chain solutions around hospital, and what's you feel are the biggest roadblock to that thought process from a channel partner or from a reach perspective?
Well, first of all, Saurabh, and thank you for having me on the panel, and a hello to all the fellow panel members. So I come from Cipla, and Cipla is India's third largest pharma company. But as far as supplying to hospitals is concerned, we are the largest, with a market share of little less than 10%. Deeply entrenched in hospital market, but still blind to what happens beyond when we supply to our distributors. We have a strong CAM approach. We have our own distribution setup, and we have dedicated hospital distributors. But I think from a patient standpoint, to begin with, there's a patient experience in a hospital has a way to go. And the COVID times taught us the hard reality that all stakeholders were stretched to deliver medicines. There were times in wave one when patients were asked to arrange remdesivir, for example, on their own. Hospitals were unable to, and the whole ecosystem was so broken that it was a lopsided supply-demand situation. But more than that, every patient was left to fend for their own, and that really exposed how broken this whole supply chain is. So clearly, we are not agile enough, and I think the demand patterns have started changing much faster than before. So the need for agility is only going up. So from what I know of SCM 4.0, the ability of bringing agility through automation, RPA, IoT, and whatnot, there is a lot of predictability that can be built in once modeling happens. But I think before that, knowing the needs of various stakeholders is important. And from an OEM standpoint, as I said, we are blind beyond the first distribution point, and there's a need for a lot more visibility of what sells where. It helps us to respond faster, helps us improve planning, reduce working capital. So of course, the OEMs are interested. The trends also help to plug portfolio gaps. I think there is a need to understand how is the portfolio to be shaped in the medium term. And the disease trends help us in planning a lot better in terms of therapy shaping with doctors, with patients, and post-hospitalization support as well. I think that's another thing which is something that drives us as OEMs. That's from a pharma company's point of view, but for a hospital, I think while we are talking about SEM 4.0 and stuff like that, there are many hospitals, especially small, which are not even clearly at SEM 1.0. They're not even looking at the total cost of ownership of what they're buying. There are hidden costs, cost of poor standardization, fill rates, stockouts, stocks not reaching the point of care, cold chain products. I think these are all which is leading to higher inventory eventually for many of the hospital players. Patients are demanding a lot more brand choices. Today, the formulary cannot afford to have just one or two because the patient may have a preference for something which the hospital is not envisaged. So eventually, hospitals need to save time and by consolidating suppliers, but eventually design processes which are around patient experience, enhance patient face time to begin with, look at patients beyond hospitals, have home delivery for post-hospitalization care, refill programs, the experience of follow-ups for patients, which needs redesign, preventive maintenance of caregivers, early diagnosis. Basically, hospitals need to rely more on their partner network for supply chain and give that additional spare time to redesign what will help the patient experience eventually. Also, for smaller hospitals, and Aknamid knows it very well, maybe around 70% of promoters would be doctors themselves. So imagine the amount of the time that they save, how much of that can go back into relooking at patient fulfillment, So I think there's a certain level of agility which new supply chain processes can bring in, but we've not traveled a long distance. And I think the disruption that's happening at the channel front is also very important to observe with the onset of all e-pharmacies, physical distributor aggregators, or Acnamid as well. I think there's a much bigger opportunity that the channel can play as a partner to the hospitals. And this value that they can add through integration with HIS will help free up the time that the hospitals badly need to. And also the new age channel partners have the ability to do risk-adjusted monitoring of credit in terms of when they receive payments from hospitals. So I think there is an ecosystem which is broken, and the new age channel partners have a way to actually plug many parts which are leaking right now. Eventually, Saurabh, if you ask me, a digital supply chain provides the much required visibility, traceability, predictability, and the trust that is required in a broken system right now.
Thanks, Sumit. I think you brought a very important point, which probably I'll ask Kaustav to comment on, especially from perspective that the variety which exists in the Indian healthcare ecosystem as well. There's large hospitals, there are mid-sized hospitals, and there are larger hospitals, much smaller hospitals, which are still operated by doctor owners or physicians. Kaustav, coming to you, you have seen this system evolve over the last few years specifically, and you've been part of some of the transformation work. I think as much as you hear Madan or Sumit or Shivasan sir on the writing on the wall that yes, transformation or digital is important, but there are definitely challenges, and hence the digital adoption by hospital is still at a very new sense, very early stage of its whole evolution, right? What you are seeing in the market, what you feel is something which will help bridge this gap or bridge this time period gap. And I often keep saying that where FMCG was 20 years back in the supply chain, hospital is probably further back. Where do you see the roadblock, and what's happening with some of the thought processes on the transformation side?
Sure. Thanks, Saurav. First of all, thanks for having me on the panel, and hi to all of my fellow panel members as well. Just zooming out a little bit, Saurav, I think when you think about hospitals and the specific need areas that they're looking to address with digital interventions today, I think in my mind, they broadly fall into three buckets, right?
One relates to digital interventions that can lead to margin accretive top line growth. How can I source patients? How can I convert patients who are coming through the funnel better? How can I monetize or maximize my patient lifetime value? How can I engage with my referral doctors better? So all focused on growing the revenue better, impacting the top line better, right? So that's one block. The second one is related to patient experience and clinical outcome. They pretty much go hand in hand. That's probably the most broken area. I mean, hardly any work has happened in that area. The first block is something that is starting to see some innovation, some changes, investments by at least the large hospital groups. And the third block is really our subject matter over here, which is related to procurement and supply chain efficiency, right? I think broadly those are the three areas that they want to be able to address. Now, reflecting on your point on why there is such a phenomenal gap between what they need to be doing on the ground versus what many of these hospital chains have been able to do so far. I think it fundamentally boils down to the fact that they don't necessarily start with a clear definition of what business problems that they're trying to solve, right? If you're starting with a solution view, okay, I need an HIS, okay, or I need a specific type of a procurement layer on that HIS, or I need a dashboard for me to be able to look at my MIS. That oftentimes is actually the wrong place to start, because you don't know exactly what you're solving for. You're starting with HIS because that's a fundamental piece that you need in your hospital system. There are off-the-shelf solutions as well as customizable ones that you can get in your system. But does it fundamentally solve for the specific pain areas that you're trying to find answers to? Okay, maybe not. And that, in my mind, is really the root of the problem, because you're starting off with solutions, then you figure out that you're not being able to answer the specific pain points or pain queries that you have in your system, and then you're trying to break fix, right? You're trying to add on layers, you're trying to break fix, you're trying to rework your workflows and processes around a broken system. So that is really my at least high level assessment as to why there is such a fundamental difference between what they need to be doing versus what they're doing on the ground. Now, zooming in a little bit more into your subject matter over here, which is really related to procurement and supply chain efficiency, I think if I have to spend a couple of minutes just explaining what are the broad buckets around we see there being pain points, right? The first one relates to cost rationalization. So I'm a small hospital. I want to be able to see cost optimization on the table so that my gross margin improves. Okay, I as a small hospital do not have access to large OEMs and principals. So what solution can actually help me do a much better job of this, right? So cost rationalization, and there are 3 or 4 different prongs of cost rationalization that large hospital groups or even small hospital groups have to be able to address to get this right. But that's really the first pain area, right? The second one relates to simplification, right? And this is often underestimated as a problem area. So, I mean, if you talk to some of the largest hospital groups in the country today, they would typically turn around and say, hey, I don't really think I need your help around cost rationalization, right? Because, I have gotten into, rate card contracts with Sumit and his team. I know that they're the very best that I can get. So I don't need a solution, right, for you for the first bucket. But do I need solutions around simplifying the whole procurement process? The answer is yes, right? Because today, my SKU complexity is phenomenal between consumables, implants, drugs. I'm literally running into tens or 15,000s of SKUs, depending on which hospital group that you're talking about. And there, because I'm not working with professional suppliers, I don't have any visibility with respect to fill rate. I don't have visibility with respect to turnaround time. And therefore, I end up working with a whole plethora of suppliers, right? 80, 90, hundreds of them. And one of their key asks is, how can I rationalize this? How can I rationalize the long tail? How can I rationalize my vendor base, right? So that my
procurement complexity goes down. So that's one part of simplification. The second part of simplification is related to workflow simplification. So I raise a purchase requisition or a purchase order basis my codification of what my SKU list or item code list is, right? How does that get translated into the code list that the vendors are working with? And your code list is very different from vendor B versus vendor C versus the 100 vendor that they're working with, right? So what do they read of that? How does that basically map back into their being able to generate the right package for me for delivery? And how do I get visibility of my fill rate and turnaround time from these different vendors that I'm currently working with, right? Which really is the third bucket. So the third pain area relates to service levels. So service levels are really related to fill rate and turnaround time, phenomenal SKU complexity and vendor complexity, but I do not necessarily have a solution or an intervention which can really give me visibility as to how well I'm tracking on that, right? Because there is a certain cost as a hospital group for me losing out on fill rate or losing out on not complying with, let's say, turnaround time. The fourth area, pain point area, sort of is really with respect to working capital optimization, right? So do I have an analytical data-based view of, what's my working capital position by vendors, by brands, by SKUs, and therefore, what choices do I need to be able to make to rationalize that, right? Ideally, I think at least outside in you get the feeling that most of these areas are solvable, but the reason they're probably not getting solved on the ground is what I explained earlier on, which is that they're not necessarily starting with a clear articulation of the key problems or queries that they need to be able to solve for. Which is why they're trying to force fit solutions into answering for these areas.
Yeah. So thanks, Kaustav. That was pretty exhaustive, and I think I'll move to Kaivan. Kaivan, Kaustav did an amazing job of capturing your pitch document to the hospital, right? And you probably spent maximum time with hospital going through this pitch document, right? And it will be lovely to have you comment on the gap between where do you start and where do you end, right? And if that's actually a problem at the hospital end, right? And some of the problems which Kaustav touched upon, they're not new, right? They've been in existence for some time. Some of them are just as a nature of the healthcare ecosystem, they are there. But how are hospitals solving for it? And you've been part of some of these supply chain work in last 4 or 5 years. Help us understand where is actually the gap, because I'm still trying to understand or figure out, pinpoint what is needed to be done to make supply chain a strategic tool to enable the digital hospital, because hospital at the end of the day is a large part of a digital healthcare ecosystem which we want to achieve.
Sure. Thanks, Saurabh. I think I'll answer it at two levels. I think first is that when you look at the context, right, the emerging price expectations of mass healthcare schemes, competitive pressure driving down patient economics, rising input costs, all of that has necessitated that the sector really re-engineer its operating model to drive efficiency. And I think providers over the last few years have made progress, right? There have been incremental improvements in looking at the supply chain. But I think what the sector really needs to focus on is a transformative design to cost approach, right? Which is basically aimed at fixing what's my target cost of healthcare delivery, depending upon what I want to charge the patient or what the payer is forcing me to charge or stipulating me to charge, and then working backwards to come up with the optimal mix of fixed and variable cost with a really first principle approach, right? And I think that's where across the supply chain, there are levers to optimize or rationalize layout, procurement, consumption, usage of manpower, which is HR, which is a very critical cost in supply chain, utilities, medical technology, the entire spectrum to really drive both clinical and commercial excellence, right? So I think fundamentally a new thought process needs to really come in. Now, when it comes specifically to supply chain, right, I think Kaustav's spoken about it, Sumeet's spoken about it. Again, I'll bucket it into three things: that codification, standardization, and harmonization. I think these three key themes will really drive breakthrough efficiency, when it comes to supply chain, right? And I think digital supply chain is clearly that unlocking lever. And I think lack of codification, standardization still continues to be a challenge, right? But I think basis the work that we've been doing with providers, I think where the efficiency really comes out is in three components. I think first is, and when it comes to supply chain, the first is around commercial excellence, right? How do I buy better? And we've seen that, out of the total efficiency release, 20-25% comes in that block. The second one is demand management, right? What to buy, how much to consume. I think that's where the chunk of 40-50% of efficiency release comes in. And the third, very, very important, is the entire compliance management system, set of preventive and monitoring controls to drive compliance, which possibly drives one third of that value. Now, in each of these three levers, I think technology very much is the fulcrum to drive efficiency. And I'll give 2 or 3 examples in terms of what hospitals are doing and actually what we'd like to see them really move towards in the next 5 to 6 years. What we're seeing, one is that hospitals are trying to bring in specific tools, which are patient acuity focused. So, for example, depending upon at a patient level, depending upon the acuity profile, you can actually determine how much is the care requirement, resource requirement, how many nurses are needed, and therefore balance your supply of resources, which is anyways constrained to meet the demand. Right. So that's one thing that we are seeing. The second, when it comes to consumption of medical products, I think there's a need for a technology-enabled, variation analytics engine, which can bring together data from patient consumption, supply chain costs, risk profile of patients, clinical outcomes. I think all of this together to really see at the granular level where are variations happening, which are your best practices across doctors, across various locations, and really drive optimization using preference cards, bill of materials, real-time requisitions, and all of that. And I think third, what we're seeing is again a lot of focus by hospitals on compliance management systems, right? Where you have automated dispensing systems to drive compliance to the formulary. Products which are not in formulary are controlled. Codification of rates in the masters, monitoring controls around dashboards, details at a doctor level, at a product level, where the deviations are happening. So I think all this, what it essentially means is that it's a combination of real-time patient intelligence, which is there in the hospital system, and the connected supply chain to really drive down efficiency, improve coordination, and improve service levels. And I think just to conclude, what I really believe that I think the next 4 to 5 years will see is actually the patient, getting connected to your supply chain, which really enables, the healthcare anywhere, anytime, and really, help drive compliance to the treatment regimen or the prescription fill rates, etc., which has traditionally been a challenge, for the Indian populace. So that, in a sense,
yeah. Thanks. I think that's a good way to conclude at least the whole perspective, because I think what you rightly said, that if patient is kept as a center point, I think the benefits are quantifiable, and it also makes I'll say the internal stakeholder within the hospital also see a outcome-based approach to change. And with that, I think unfortunately we're running short of time, but I'll just have a quick round from Shivasan sir and others to probably have a 30-minute brief conclusion of what you feel will be the next 2 to 3 year game plan on digital health, especially from a hospital and supply chain perspective. I think Kevan did a good job of making patient a center point of the transformation to drive the change. Will be good to hear your views as well.
Yeah, so part of the challenge I spoke about earlier was adoption because of the skill level of the people, especially in the smaller hospitals. So I do see an opportunity to create, for instance, the role of a shared resource who could actually help a large number of small hospitals to navigate this journey. So in my view, the next few years should see the emergence of these shared resources in the marketplace.
Thank you. Madan?
Just adding on to what Kaiwan mentioned, right? So while many physicians and even the healthcare staff may resist changing their preferred tools and supplies, whether that be a headlamp or a patient implant, right? Demonstrating how that preference can be tied to both patient outcomes and the cost can get physician buy-in for implementing any improvement plans in the healthcare supply chain. So moving the management of supply inventory away from physician preference, right, and integrating these steps into the supply chain can provide a much more efficient solution moving forward, allowing the supply chain team, especially to see inventory gaps, the process repetitions, and that also frees up physicians' resource to focus on patient outcomes. So I think this is something that we need to look at moving forward.
I'm keenly looking forward for those good days, Madan. Sumit, why don't we go with you?
I just want to add one thing from what I've heard from everyone. I think the role of insurance companies and hospitals coming together to generate patient-specific intelligence. I think that is a wave which will drive a lot of things because there is an interest in IPD and OPD of the insurance companies as well. And that I think in a way is going to build that layer that is required around which the new wave of digitization can pick adoption.
Very important point. I think we insurance is another area we can spend another session on. But I'll, given the paucity of time, Kaustav will love to conclude this with you.
No, I think it is increasingly becoming a strategic imperative. I mean, it used to be a nice to have at some point of time, but now with pricing controls, greater regulations, greater proportion of scheme patients coming through the door, it's imperative that you have to have the ability to control your costs and your service levels better. And as Kaiwan did mention quite effectively, you need to be able to connect your supply chain back to your patient, to your demand point as well. I think while that's the big picture movement, my sense is that you need to be able to start with the basics, which is just the data standardization and having analytics right as a layer on top of that, right? For you to be able to take smart, intelligent decisions. I think oftentimes we find that people are grappling with non-standard data, non-standard vendor, SKU list, different versions of the pricing master, and for you to be able to make a start, you need to have that one unified view of data and then have intelligence built in on the back of analytics riding on top of that. I think that's the first step. But the final vision is what I just started my discussion with.
Yeah. So thanks, Kaustav. I think that will differentiate planning and execution, right? A crack at the data, right? So
absolutely,
I think that has to be the core of what we are planning or what we are dreaming with digital need of supply chain. Thanks a lot thanks a lot, everyone. It was we were able to achieve what we wanted to achieve on the discussion panel. Thanks for your time.
Thank you.
Thanks, Saurabh. Thanks, everyone.
Thanks, everyone.
Bye.
Bye.
Thank you, Saurabh and the panelists, on your ideas. We look forward to hear more. Let's now see a small video from our sponsor, Optum.
Health is an important part of life. It impacts relationships, careers, how we reach our goals and dreams. Managing our health should be simple and effective, with smart, seamless experiences that connect individuals to the right care and support. By drawing from broad data sets that create a foundation for deep, insightful analysis, applying experience and expertise to deliver care plans that improve health, providing personalized services targeted to the individual, addressing physical, mental, and financial needs, reducing costs and delivering healthier outcomes. By meeting each individual where they are in their healthcare journey, by helping them to know how to approach healthcare challenges, what issue to tackle first, and where to go for help, people are empowered to take ownership of their health. And good things happen. When the healthcare system is easier to navigate, barriers collapse and care becomes accessible. And as clinicians, employers, health plans, and individuals are guided toward the next best action, costs decline and results improve. At the forefront of personalized, connected healthcare is Optum, so people can focus on what matters most.
Moving on to our next panel discussion, and the topic is Future of Radiology and Imaging with AI. Deep learning algorithms are peering into MRIs and X rays with unmatched vision, from radiographic pathological data to clinically meaningful endpoints. AI has taken medical imaging to an all new level. AI has shown impressive accuracy and sensitivity in the identification of imaging abnormalities. Its adoption remains a challenge in India, however. Welcoming our panelists, Dr. Namita Sinha Varma, Head Global Teleradiology, Aster Medical Imaging, Aster DM Healthcare, Dr. Deepak Patkar, Director Medical Services and Head, Department of Radiology, Nanavati Max Super Specialty Hospital, Pankaj Sani, CEO, Medanta Group Global Health Limited, Dr. Adam Shee, Chief Smart Health Leadership Center, Institute of Systems Science, National University of Singapore, and our moderator E. Kumar Sharma, Deputy Editor, FE Digital, the Indian Express Group.
Hello, everyone. Welcome to a session that deals closely with diagnosis, and today is seeing increasingly blend of sciences and nearly a space where engineers and doctors are more or less working together. To discuss the topic of discussion today, the future of radiology and imaging with AI or artificial intelligence, as they call. I don't know how artificial intelligence can get, but that's what we call now increasingly, and it's become the buzzword now, and ML and all the other alphabets, letters of the English alphabet. As the session has been called, actually, the future of radiology and imaging with AI, we have a distinguished panel of speakers, each bringing in deep insights from their respective areas of work. If I could begin with request each speaker to share some opening remarks on the way they see this from the domain of landscape of radiology and the way it's changing and the kind of approaches that are being adopted here, and what they see as the factors which are triggering this change. We are still a long distance away from AI actually kind of dominating the way we do things. I think we have patchwork of the entity summit coming up with one area of, say, oncology, where we'll say backbone, the way we read a backbone, or the way we read some other element of say. So it's not a comprehensive set as yet. There is still some distance, but what is triggering the change? And overall thoughts in terms of this, the way the topic under discussion here. May I begin with Dr. Deepak Patkar, if that's fine with you, Doctor? And then we'll go on to Mr. Pankaj Sani and Mr. Adam, and of course, Dr. Namita. I'll approach each individually.
Basically, radiology, all of us know, is at the forefront of diagnosis, and it has become an integral part of patient management. What has happened is the growth of radiology images has far outweighed the number of radiologists that the country and the world is producing. The number of scans that happen, number of X-rays that happen, number of ultrasounds that happen, and the complex imaging like PET-CT, interventional radiology, the numbers have exploded over the last decade or 2 decades. The number of radiologists have not really grown. If you look at medical colleges, and that's where across the world there is a severe shortage of radiologists. This actually led across Europe and America to look forward to improvising and improving the efficiency of radiologists. So what I could do over 8 or 10 hours of working, how that can be efficiently increased. And that's where I think AI is completely taking over. So doing something that you need not do can be taken care by your technologist, your executive assistant, etc. But AI can do that much more efficiently. That's where the AI was born. The other area where the AI is really useful is when you have thousands of images and you have to make a diagnosis. AI can really shortlist certain things, point something to you, and then the diagnosis becomes easy. Also, it aids in what is called as pattern recognition. So as a radiologist, your brains are trained to look at pattern recognition. You've seen it before 10 times, 20 times. And in a situation where you have not seen it, if AI can help you, the pattern recognition of common disorders and rare disorders. And that's where AI started up, and that's where it is heading. Also, it is very, very useful in deciding when you have a busy schedule, what needs to be handled quickly. So emergency, semi-emergency, and routine. That was completely relied upon on your technicians and the front desk. That need not be done now. And this is my opening remark. That's where the AI in radiology would really be useful, and it's coming in a big way.
That's very nice. Dr. Namita, your thoughts in terms of I think as Dr. Deepak has pointed out, there's a talent issue, which is why we don't have enough radiologists. So we need the technology, we need other elements, perhaps at someday precision medicine, but in the meantime, perhaps reading patterns, as he says. Is that what's your reading? How much? Where are we on this journey to actually transform ourselves in this, and what do you see as your view?
Right. So yes, as Dr. Patkar said, there's a huge demand-supply ratio about the number of images that are being conducted and the number of radiologists who are actually reading. And not just that, it's not just based on the number of images that are being done for patients. It's also that in the remote areas, you don't actually have talent who can read these images as well. So what we are doing, and when we did our first study with one of the AI companies for developing a chest X-ray algorithm, and we had given this talk in actually smaller hospitals where there were conferences of preventive and social medicine. And they had then taken these in mobile vans using these digital X-rays, mobile X-ray units with this algorithm to actually triage X-rays and to screen for tuberculosis. So it was done in the remotest areas, in the villages of UP and in the North India, where there was a high incidence of tuberculosis. And because people used to live close together, if before it gets detected, because the patient has got too many symptoms, it has actually spread to the neighboring houses as well. So to be able to screen for tuberculosis early, to be able to catch it early, was a program that they were conducting to be able to control this kind of epidemic that was there. This was the pre-pandemic area when tuberculosis seemed to be the biggest problem in the country at that time. And a good AI tool at that time would be of great use, because you need somebody who can actually give you some kind of an objective answers to the CT. This is pattern recognition. You're looking for ground glass opacities, you're looking for ground consolidation. If you can train the AI tools, and that's what we got a lot of people who had come into the AI tools to be able to detect COVID, because they realized that a pattern recognition through a lot of images and to generate a score is all that was required for taking immediate decisions about patient care at that time. So that is how the pandemic also kind of, drew a lot of attention towards artificial intelligence and its utility in kind of handling things when you didn't have that many radiologists available on the ground.
I think that's very important, and thanks for that, Dr. Namita. Mr. Pankajani, what you operate and you this challenge of actually reaching out to a larger audience, and given the way there is a technical component and also the talent issue, both from the those who actually have from an engineering background as well on the AI front, and also at the same time. And since we don't have a comprehensive tools really, we have in select areas. How do you look at the way you seeing the rollout happening, and where do you see we stand on this journey?
So I agree with many of the earlier speakers in terms of the fact that there is a shortage of clinical talent, there is a huge demand, there is an increasing workload in terms of whether it is the pandemic or just the general growth of healthcare. I think these are all very clear and very obvious situations. At present, a lot of what is happening on the AI front is very simple, very elementary kind of algorithms. But we need to start to think about how do we bring other information into play, the way in which we give this information to the doctors today. So it could be things like the patient's history. It could be things like the diagnostic details from laboratory reports. It could be the other treatment modalities. It is all the other information that a clinician uses in their normal course of training to provide a better output or a better diagnosis or a better report. This is missing for the large part in AI today. And so what we need to do is that we need to think about how are we reorienting our processes. I think the technology is far ahead of our processes. We need to think about how are we reorienting our processes. How are we reorienting our mental thought process into technology, the technology that we have, and to be really important, able to the power of the clinicians that we have. And it is not a question of replacing the clinicians with technology. It is a question of empowering the clinicians more and more to be able to do what they are best suited.
Thanks so much, Mr. Sani. I think very important points. I think, and especially the points that you raise about integration and issues around change of mindsets, especially at a time when actually we are talking of digital healthcare. We're talking of health records being made digitally made available, and I think these issues become all the more important. If I can now turn to Dr. Adam, you given your global perspective, you engage with several opinion makers and also both in the private and the government domain. How easy is it to implement the medical health record that are, shall we say, NLP compliant, natural language processing compliant, which Mr. Sani also mentioned about ability to integrate so that the doctor is able to do a much more informed decisions, whether it's about the patient history and all of that, along with the radiology findings, and more so in the context of getting smaller players also involved. Like for instance, the speakers that we have here, they are from major hospitals. They have a huge chain. They perhaps would be a better place to do some of these things. But imagine for a moment a smaller hospital, individual doctors, individual radiologists. How we bring them into this framework? What's your experience in this, Dr. Adam?
That's a lot of questions. So I'll try to answer them.
Whatever you can recall. We will pitch in with more.
Sure. So in terms of ease of implementation, which is going to relate to the second part of my question, it depends on what you're trying to implement. So NLP, as the general understanding is, you try to interact with could be the electronic medical record or the clinical information system in a clinician-friendly manner. Now, the problem is this type of interaction really depends on your clinical workflow. What type of clinicians, what setting, and what context. So if you're talking about a normal GP kind of setting, NLP wouldn't work because you can't have a day-to-day conversation with the computer. It's just not smart enough because you can't frame the context. You cannot limit it. That's the reason why it's called artificial intelligence. It's artificially built to answer certain things in certain contexts. But if you narrow it down intelligently, because you know that certain clinical workflows are a lot easier, and you said, say, radiology. Now, even within radiology, there'll be different types of modalities, different type of diagnosis, and some of these are actually very straightforward. So if you're saying that, look, I'm looking at, for this particular radiologist, he or she is looking at chest X-ray for TB, for example, as mentioned by Dr. Namita, that the context is framed. It's going to be a chest X-ray. You're going to be looking at lungs, right? And you're going to be looking for TB. This type of constraint, smartly done, will allow the system to function properly. So you can actually ask questions with certain keywords, and you can train the system. Now that would be fairly easier to implement as opposed to, again, as I mentioned, GP clinics, you go in and say, oh, I have a cough. What does that mean? It covers the entire universe. So this is the context we have to be mindful. What is the clinical workflow in context? So with that, when you implement it, regardless whether it's a big or small hospital setting, as long as you're clear on the scope, again, controlling the clinical perspective well, the technology can come in and support. What I've seen in most places across the globe where AI gets into trouble is when people don't understand what it can do or what it can't. And just starts thinking that, hey, because, I've seen case studies, IBM Watson's come to mind, so many case studies, you can do this, they can do that. So logically, if you can do ABC, I think they should be able to do X, Y, Z. And they try to implement it with a lot of unrealistic expectation. When you have expectations that are set up too high, you're bound to be disappointed. Again, because a lot of this stuff that the solution providers, they'll present the best side of things to you, the case study or whatever you, very nicely crafted narrative that they can diagnose stuff, etc. But not really, it's not a one-size-fits-all solution. And it is important to understand that in the technical perspective, images are actually a lot easier to apply AI because pattern recognition is one of the main first few areas computer scientists actually tackle with regards to artificial intelligence. So facial recognition, which they use for identification with a few. So they actually do to that extent, even by the way you walk, they can triangulate and say, hey, this is most probably Adam. Because these are fixed aspects of things. So again, when it comes to imaging, and we must be intelligent. You can't say because it's imaging, therefore the chest X-ray is the same as the left hand and the right hand, and you don't put markers. The solution wouldn't know it. I guess you guys are familiar with what I'm saying. You can take the chest, you can take the X-ray of the left hand, you flip it, it looks like the right. But if you don't put intelligent markers or snowmat codes, the humans or the computer wouldn't know. But this is a little stuff that sometimes we have overly high expectation of AI. It's like you should know, right? Because you're a computer. So this is stuff that we have to control. Again, it all boils back to the clinical perspective, understanding what AI can do today. I don't know about 5 years from now, but there are limitations today. And from there on, it's an easier journey for the hospital or for the person implementing it. I hope that helps.
Yeah, but just a quick point before I go to Dr. Namita is what is it that AI can do at the moment, which you think perhaps maybe if you were to pick one thing which you think we are fairly decent position to perhaps do.
AI can do a lot of stuff, but given this topic, we're talking about radiology. So AI can definitely. This is actually mentioned by the earlier speakers. AI can do pattern recognition very, very well, extremely well. The problem is sometimes you have to tell them what they're looking for. So if you just show them one X-ray and it says look for something, then it really depends on what you're programming to look for. It wouldn't know. But if you're specific, say look for TB, then you reach out into its databases of information logic. It will look specifically for TB. But it could be a situation where this patient actually has lung cancer, and the system actually isn't trained for that. So when a radiologist look at it, immediately just by looking, say, hey, there's a nodule. But the AI, if they're not trained to look for lung cancer, they'll say, hey, actually it's clear, it's perfectly fine. Again, it goes back to knowing what it can do and what you have purchased, what you have trained, and back again to the clinical practice. Yeah, that's important.
Yeah, thank you so much. Thanks, Dr. Namita. Dr. Adam touched upon TB again. A few days back, we had a talk we were speaking to Dr. Soumya Swaminathan at WHO in the context of the new virus variant, and she mentioned also about TB and the importance of it. This is an often discussed topic in India, considering that there's one death every minute or so, because it's hugely important. Your sense in terms of how you see AI, do you see this as an element which can be leveraged at the moment? Because essentially this is involving remote locations and reaching. What is your sense in terms of how equipped are we in that journey? And from that, I would want to come to after your thoughts. Similar question to Mr. Sani and also Dr. Deepak on what they feel about this aspect. I also want to add the component that when we look at this, let me come to that later. First, we begin with this, Doctor.
So yes, so what the algorithm that I was talking about had been trained to isolate about 9 pathologies in the chest X-ray. So it would look for consolidation, it would look for pleural effusion, pleural thickening, some nodes. However, as Dr. Adam said, it can do a lot, but there are things that it cannot do. So it could look for anything which was abnormally white in the chest X-ray, and that is what we were looking for. We were looking at all kinds of TBs that can present, either as a focal consolidation or as small nodules or as miliary nodules or as interstitial patches. So whatever it was, we were looking at anything which would cause an abnormal bright whiteness or brightness in the chest X-ray. So what it could do is it could tell that this is absolutely normal, where both lung fields are absolutely clear and there's nothing there, or there is some kind of an abnormality, and mark it out with a heat map, saying that there's some area of consolidation, abnormal whitening, or there's some area of nodularity. What it doesn't say is that this is TB, but how we are seeing it is if this is absolutely normal with an almost 94 to 95% specificity, then those are the chest X-rays or those are the patients that you don't really need to worry about. Wherever an abnormality is picked up is where you need to investigate further. So you will go ahead and do a sputum for every if the patient has cough, or you will go at the IGRA. You will do tests further up it to find out whether there is TB. But what it does, it just helps you to target which part of the population do you actually need to test further. So it cannot really tell you that there is significant TB in this patient. That still depends on the pathology on the sputum sample, on the blood test. But what it can give you, and on a gene expert, what it can tell you is that this patient does not need to be tested further because there is no pulmonary TB. Now, the fact that there are other sites of tuberculosis is a discussion for another day. But right now, we are talking about pulmonary TB because these are the ones that rapidly spread to neighboring communities, especially where people live in very close, communities. So what it can do is it can tell you that these are the normals, don't worry about them. And these are the abnormals, which show some abnormal opacity. So probably you need to test them, especially if they're classically in the upper zones and, if there's some cavity, which are, from a radiologist's point of view, things which point more towards a diagnosis of TB.
Yeah. Mr. Sani, your thoughts on this? And the other point which I also wanted to include in was the aspect like when we go to remote locations, for example, color Doppler and others, it needs an intervention. It needs a specialist also. So how does one therefore, apart from this second point about what we discussed, your thoughts, this aspect of where in some areas of radiology, we actually need the specialist on the spot as well. So some thoughts of how do we deal with.
So I think that, look, there is no doubt that the use of artificial intelligence, the use of technology is going to help us deliver the services better. But I think that what ends up happening is that we very often mistake this as some magic wand that is going to suddenly, solve all of our healthcare problems. I am yet to find an AI algorithm that can start treatment of anybody. So I think that the way in which we talk about AI and all these things, I think we need to get a little bit rational around a lot of this. The second thing is important is that we need to understand what is the problem that we're solving. So when you talk about, for example, going out into the community, whether it is in the rural areas or whether it is in the urban areas, and you talk about doing things like screening for TB, that is a very different kind of a problem statement from, say, when you are actually diagnosing or treating a patient in a hospital. And we must be very clear what is it that we are solving for. There is no magic AI. AI is nothing more than a mechanism for us as humans to teach the computer to learn on its own and get better and better by providing it with more and more data. So what needs to happen is when you start to think about things like screening in the communities, you need to actually move just beyond taking a chest x-ray and putting it on an algorithm and saying, is TB present or not present? Because we need to start to think about all the other factors that go in. We need to start to enter those data points in. We need to start to be able to provide public health officials or the government with information to say, where is it likely to take, where should we take this x-ray van to actually do the screening so that there's a highest return. We need to start to get into predictive analytics. We need to start to put other data points. Most of health challenges don't come because of a particular intervention or a particular diagnosis. They come from other things. They come from our environment. They come from the way in which we all live, the kind of lifestyle that we lead. So when we are talking about something like TB, which is essentially a public health issue, we need to start to think about more than just taking an x-ray and putting that in an algorithm. We need to think about what are all the other factors that are contributing to this. How densely are people living? TB is going to spread in a different way in a densely populated community and a different way in a sparsely populated community. This information also needs to feed into these algorithms to be able to provide public health officials to say, where is there likely to be a spread? If there is a positive case, how quickly do I need to intervene? And it is not only TB, it's the same logic when you talk about COVID, or it's the same logic when you talk about any other communicable disease. So this is one part of it. The second part of it, and may or may not be relevant for TB, because actually the government has done a fantastic job, and the TB officers, the district TB officers do a fantastic job of actually addressing TB as part of the challenge. But what happens? You give a diagnosis to a particular patient and you say that you have this disease. And if the next response is you have to please travel 500 kilometers to find the doctor that can cure your disease, or you have to travel 100 kilometers to find the medicine that you can use to treat your disease, this is not helpful. So AI is a part of the healthcare delivery chain. And we must not get caught up with saying that this is a magic wand. So what I personally feel is that our focus now needs to be to think about the other aspects that need to be stitched to this. We will continue to make the algorithms better, to do better job of diagnosing diseases, better job of doing pattern recognition. That will evolve. Our parallel focus needs to be thinking about what are the other things we need to stitch together.
Yeah, no, thanks. I think very important and very well articulated. And I think there'll be many who will resonate on this point with you. And I see Dr. Deepak already nodding and others also seeming to agree. Dr. Deepak, Ms. Tanya has listed out a whole host of things.
Completely agree with Pankaj. So all of us work in silos, and I know what I want. The other guy doesn't know what I want, and I don't know what the other guy wants. Having said that, AI has come in a very, very long way. So whether it is talking about metros or remote areas, a lot of people are working on both the aspects. I'll take the first aspect first. As Dr. Namita said, beyond chest X-ray, a lot of things are happening. So we talk about, we have an AI model which is meant for stroke patients, hyperacute stroke patients, which is called as RAPID. So what it does is it helps the radiologist and the neurologist who's treating the patient deciding based on perfusion imaging and diffusion imaging whether the given patient is right candidate for thrombectomy or thrombolysis. It gives you in a matter of few seconds. The server is based out of America. It gives you in a matter of few seconds whether the patient is treatable or not treatable, whether it is within the window period or beyond window period. A lot of people are working on microcalcification detection in breast cancer, which is very, very important again. A lot of people are working on detection of polyps and deciding whether they are malignant polyps or benign polyps. Beyond colon, beyond breast, beyond chest, in the brain, in cases of dementia, volumetric analysis of brain, what kind of dementia the patient is suffering from. Algorithmic approach is not staying only as a part of images. I have seen a PACS which is very, very intelligent. So it tells the radiologist the flow of work that he needs to work with. Which patient has to be given priority appointment, which are the emergencies. Also, it sets up kind of multidisciplinary meetings, the PACS itself, with a neurologist, neurosurgeon, oncologist, and the radiologist and pathologist, etc. at a given time, with all the images of the given patient, all the history, the past therapies, etc., available for all of them to look at simultaneously. So whiteboard analysis is possible. So on metro front, a lot of these things are happening, and there is a big support. As Pankaj said, when we talk about remote areas, all of us know that no radiologists exist in remote areas. So a lot of companies are working on handheld ultrasound probes, or POCUS as it is called. So you reach the patient at remote area, do the standard given scanning. An ultrasonologist is not required, radiologist is not required. A midwife can actually look at, so there's work going on detecting dysplasias of hip, the congenital hip dislocation by IABIs or midwives. So you can just put a probe there in the given direction, and basic simple turning is required. And based on the data available, very, very early detection of DDH can be made. A lot of people are working on pleural effusions, hematomas, etc. So all these things are happening on multiple fronts. The idea, as Pankaj said, is to stitch everything together and maximize the benefits to the population. And that's what we are here for. Thank you.
Thanks so much. Dr. Adam, again, important points raised by Deepak here. Your view in terms of the way when we look, for example, in stroke, how real is the scenario today that because AI can be very useful in stroke, because time is precious here. If you are able to spot the blood clot at a very in the quickest possible time, it will help the surgeon that much more. Where are we in terms of having a situation where actually this is ubiquitous or you think there are still a long journey there?
It's a very difficult question to answer. It depends on what you mean by timely. What is acceptable level of care? Also the point at which intervention is actually made. So I guess definitely technology can play a huge part depending on how you design your solution. But there are other clinical symptoms that is just as useful without using tech. So if you use a combination and you do have the relevant equipment in place, yes, it can help. But I think it's not just tech alone. It'll be the clinical procedures, intervention. So case in point, if someone has a stroke at home, and you want to actually get them to the hospital, do you actually have telemedicine at home that to help diagnose? The chances are very low because this will be complicated equipment. Is it available on the ambulance? If it's available ambulance, and perhaps you can actually do some triage and prep for surgery, etc. So again, it's not just tech, but your overall clinical procedure. Yeah. But all in all, think of it as a tool that your medical doctor will be using. So any tool, all tools are good. Some are extremely useful. Yeah, it depends on how you use it.
Yeah, it depends on how you use it. That's very important. Yes. Dr. Namita, as I keep looking at the clock as we are discussing, if we can just touch upon two concluding points where I can get each of the speakers to dwell a bit upon. As I can gather from the viewer's perspective, what I'm getting to gather is that there is element of cost which comes in, which many talk in terms of when we move in this journey, how are we going to see from the cost perspective, the accuracy perspective, especially when we are dealing with remote locations and handling all of that. And secondly, the way you see as your immediate priorities. I mean, you in your field, really, what you see as your immediate priority. And for this space in radiology, what you think in the Indian context, which should be the immediate priority.
Right. So the way I see artificial intelligence, and we've been approached by a lot of artificial intelligence providers who cater to different things, as Dr. Adam said and as Mr. Sani said. Not one of them gives you a complete solution. You have somebody who will help you with lung nodule detection. You'll have somebody who will help you with macrocalcification detection. So none of us give you a comprehensive view of what's happening with the patient. You are able to, target only specific things. So it's a long time before it actually sits on a desk and can type out a report. That's still a radiologist perspective. When you see everything, you go through everything, have the patient's history, have the patient's family history, the patient's complaints. All of that has to be tied down together before you can give out a report which is beneficial to the patient. Just detecting something is not going to be of any use, right? So therefore, I say that it is an AI and for all these last 5 years that we've been working with different people for developing algorithms and for kind of putting them to use it ourselves. What we realize is that it's like one very smart postgraduate that you have. If he detects something and if that the sensitivity for the detection is very high, you would believe him and you would go ahead and try to see whether it actually exists. But you will still want to go through each section of the scan by yourself to make sure that nothing is being missed out. So it's a good aiding tool. It's good as an augmented tool, but I would still say far from replacing radiologists. Hence, how much would you like to pay for the augmentations of the program is a cost factor that you'd like to say. In remote areas where you don't have radiologists, if you have a tool which can actually triage X-rays, tell you which are the ones which need immediate care, then that's beneficial. As Dr. Bhatkar said, Rapid AI is working on the stroke program where it can immediately tell you that this patient needs a thrombolysis or a thrombectomy. Now that happening in a remote area is of no use because you don't have a trained neurointerventional guy to actually do a thrombectomy. So even if you use the algorithm, unless and until you actually have the talent who can act on what the report is, AI is just going to be a tool which can aid in the diagnosis, but it's not going to be something which can replace patient, the reports from a radiologist, or it is not something which is beneficial if you're limited by the clinical talent of the other, the other clinical specialties that you have.
Yeah, very important point. Finally, your priority before I go to the others. Any thought on the immediate priorities, both for this sector and yours personally?
So my priorities would be using AI in a way that it can actually decrease my turnaround times when my loads are high and improve my quality of reports. So there are AI tools which work on emergency CTs. So we do polytrauma CTs and to pick up 6 things with a relative high sensitivity. So if I have something like that, and then I have a lot of polytrauma CTs because I have a central person who's sitting there and reporting from across all Aster hospitals, then that will give me the confidence that, at least the brain bleeds, the infarcts, the chest, the rib fractures, the pneumoperitoneums are not being missed at that time. So that is the kind of confidence that will give me. So if it gives me a better quality for some certain things, and if it reduces my turnaround times, then that's beneficial to me. However, as I said, it's still largely limited by the kind of radiologist who has to finally sign off the report.
That's so very nice. And it always scares us when they say AI is going to replace a specialist. I mean, that's often said for journalists. They say you will be irrelevant tomorrow because AI is going to replace journalists. You don't need to write.
Long way to go, I would say.
So it's very, very comforting to hear that, you still at the end of it need the radiologist. So, Mr. Sani, with this very comforting thoughts from Dr. Namita, Tell me what your thought is quickly as a wrap-up round in terms of your immediate priorities in this space. She mentioned a few for her. What would your be in the way you look at it?
So I agree with what Dr. Namita said. I don't think that AI is going to replace a radiologist anytime soon. But let me also caveat that by saying that the radiologists who use AI will replace the radiologists who do not use AI. And I think that is a very important point for us to understand. And I don't know whether that will equally apply in the journalism field. But my guess is, generally speaking, those who are not willing to accept change will be left behind, because the march of technology will not stop. And that, in my opinion, is largely a good thing, that march doesn't stop, because it will help us in many ways. And the 4-5 ways in which I think that this will help us is that, one, as Dr. Namita also mentioned, it will improve our efficiency. So whether that is turnaround time, whether that is actually being able to process things in a smarter way, that efficiency should generate cost reduction. Otherwise, it doesn't really help the patients too much. And that is what one of the important aspects are. It will also allow for this aspect of skill shifting, or making certain skills which are scarce more broadly used, or listing skills in a better manner, by being able to, say, eliminate the unnecessary scans from being reviewed by a radiologist, and so on and so forth. And finally, and most importantly, it should elevate the quality of care. So these are the 3-4 things that technology should be able to provide us. But in terms of, as I had mentioned earlier as well, what my real ask is, I agree with Dr. Namita that, there is no one solution provider that's actually able to give everything. And I actually don't think that one is likely to come in the future as well. So my hypothesis is that we will actually have to create an ecosystem of partnerships, and an ecosystem of partnerships between various different types of players, doctors, hospitals, tech providers, AI companies, operational excellence people, people in the field, public health professionals, etc., is what is going to be required. And the core in that ecosystem is actually going to be, how do we actually start to trust each other, start to work together to actually ensure that you're oriented towards the most important goal, which is addressing the needs of the patient, rather than our individualistic goals of each of these partners, which is addressing the maximization of the benefit for them. I think if we reorient our thinking around this, that is the only way we will be able to create these ecosystem of partnerships, because I don't think anyone will be able to do it alone. So the need and the desire that I have is we are actually able to work very aggressively on stitching these partnerships together, focused on ensuring that we are delivering the best care for the patients.
Thank you, Mr. Sani. Dr. Deepak, ecosystem of partnerships, there couldn't have been a better way to kind of, put it all together. And I think your thoughts there, and any concluding remarks.
Yeah, Pankaj said exactly what I was thinking. I would like to add a couple of things to that. Is government and the larger institutes need, something like IITs, need to play a very, very big role. Everything, as I said, is happening in silos. So training the residents while they are in their MDs and DNBs is very, very important. How to optimize what you have, the resources. All the residents work with limited resources. So if government or big medical colleges can take care of that. So training is one. 2 is data sharing. So it's an add-on point to what Pankaj said. Data sharing is very, very important. I see 5 cases in a year. Namita sees 10 cases in a year. You add up to that across the country, it will become thousands. And so AI will be helped. Even the residents will be helped. Third point that I would like to talk about is the cost. All these things come at exorbitant cost. So unless we optimize the resources, reduce the cost, all of this will remain theoretical. So 1, data sharing. 2, training. 3, optimization of cost. 4, there have to be stringent government laws as to how to share the data. We have no habit of following HIPAA compliance. So unless you really optimize the data, keep it secret, and use it only for research purposes, it's a disaster in happening. 3, also the solution to what Pankaj has been kind of harping on is hub and spoke model. So hub, we have strong hubs. So if you use the spokes properly and optimize the hubs, a lot of these things can be taken care of. So what is available for metros will be available for smaller towns and villages as well. Third is, we all know that we will not be replaced. We should have confidence in us. Neither the lawyers, nor the doctors, nor the radiologists. The simple example is pilots. So autopilot mode came 20 years back. Everybody thought pilots would get optimized, pilots will get obsolete. That has not happened. Two, cars are coming without drivers, so driverless cars are a reality. But I'm sure on the Indian roads that would probably never happen. So we have to be optimistic, and as Pankaj said, as Namita has been saying, optimize the use, learn with it, go along with it, and you'll be a smarter radiologist. The bottom of the pyramid will get wiped out with AI. The top of the pyramid will always stay with us. So we should have that confidence. Thank you.
Very well said. I think very comforting and very nice, actually, the way you articulated. Dr. Adam, we are really woefully short of time. 30 seconds, your concluding remarks. You get to have the last word.
Actually, the beauty of being the last person to go is that the other speakers have covered the important points. I totally concur with that. That's all I have to say.
Lovely. It's in this era of huge debates and argumentative Indians, it's so very nice to have people all in sync with their thoughts and so much in tune with the technology. Thank you so very much. This has been a very insightful session. We've been constrained for time, but really thank you so very much, each one, for taking time out.
Thank you, Kumar and panelists. Now playing a short video from our sponsor, Cloudera.
Have you ever wondered how we sequence the human genome, or how we'll send humans to Mars? Well, at Cloudera, we believe that data can make what is impossible today possible tomorrow. Cloudera.
And we now move on to a special address today on digital transformation, the way ahead, challenges faced in conversions by Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group. Over to you, ma'am.
To begin with, I would really like to say that information, data, is what healthcare is all about. It's information about the patient, the demographic, the lab values, the information about the pixels of the diagnostic tools, whether it's the CT scan or the angiogram. Everything is information and data. Processing this better, organizing it, sharing it, and using the digital environment to enhance healthcare is really an incredible journey that I believe all over the world, different countries, different hospitals, different individuals, different tech companies have embarked on this journey and are at varying stages. I think that the purpose or the intent or the inspiration of this journey must be very clear, and that is to enable better health access, better healthcare, and lower cost at higher quality, to enable universal access to healthcare. And that's what this journey is about. Just sharing some of the thoughts, I think we must begin by the ambitious and very appropriate digital health mission of India. I'm extremely happy that this has been launched. This has been something that many of us who are advocates or evangelists of information technology usage in healthcare have been working on. Some of you may remember that almost 20 years ago is when Apollo launched its telemedicine initiative. Almost 9 years ago, we began to work with the government on creating unified standards of data capture, and went on to various other committees and subcommittees and recommendations and reports on standards for electronic health records, universal standards for health data capture. So SNOMED is one of those initiatives. And as the world has evolved, we're looking at LOINC, we're looking at HIPAA as a privacy standard, we're looking at messaging standards. So all these, if they coalesce into a single framework or strategy for the country, and various players, both large, small, individual doctors, all begin to get more digitalized on the framework of this National Digital Health Mission unified strategy, then the country will begin to see more and more unified data. Insurance companies will be able to put together better information and better predictive models. Hospitals will be able to share not just the video consults, which are very critical, but also be able to share care pathways, to use artificial intelligence to enhance the quality of care across the spectrum and to reach out to others. So this is, I think, the phase that everybody is now in, of searching for their digital solutions to include and to actually engage the customer, the consumer, the patient family, to connect and to enable doctors to go paperless and completely digital, and healthcare environments to be interconnected. That's the journey we're all on. Before I deep dive into some of the potential and the roadmap and the pitfalls, I want to say just one thing, and that is that healthcare needs to transform and evolve from a current sick care system where we take care of the patient when he comes into a hospital with symptoms, or he meets a doctor saying, my stomach hurts, or he rushes to emergency with chest pain in the middle of the night. In today's world of genomics, of connected environments, of digitals, of wearables, we have to move to a health care, a well care, a proactive care, which is personalized. And many years ago, I was at a conference where I heard Bill Gates' father, not Bill Gates, Bill Gates' father speak about the 3 Bs which will transform healthcare. And this was almost more than a decade ago. And these 3 Bs are biology, because the day the genome was deciphered was the day that personalized medicine began, and we understood why one individual gets a certain health problem before someone else. But when you juxtaposition biology, and the cost of genomic testing has come down from multi-million dollars to under $1 today. But it's when you juxtaposition biology with bytes, which is computing capacity. So we're taking this information, this data, these pixels, this knowledge about not just individual, but multiple individuals and population, because the computing capacity has enhanced as the cost of computing has come down. So biology, bytes, and the final extremely important one is bandwidth, because it is with the bandwidth that we can take a doctor from a high-end hospital and let him consult or guide a small nursing home or a clinic in a rural area. So the combination of biology, bytes, and bandwidth is transforming healthcare. And in this transformative journey, there are many things that can happen. So this aspect of bringing everybody on board, but the hospitals also changing and enhancing the way they do things. So our project called Connected Rooms, where we're using connected devices to put into the ecosystem so that literally every hospital bed is being monitored 24/7 by the nurse and the doctor who is sitting in a central command station, as well as at the bedside. Because their operations automation will say that a nurse does not need to be writing copious notes, all data is auto-captured, and every aspect of the patient which is being monitored is also being seen by a doctor at a central station. And the next step of that is that we evolve more and more artificial intelligence-enabled models for sequencing and early prediction, so we know prior to the event occurring. Because these small symptoms came up, these could be computed to give early warning to doctors saying, look, this person's, their glucose is rising, their sugar is rising or dropping, their blood pressure is dropping. Because of their biochemical value, they may be going in for an attack in the next 2 or 3 months, or early warning symptoms of sepsis, which is one of the most scary things in ICU. So just putting a deep level of automation, digital monitoring, Internet of Medical Things into the hospital is one important step. Then expanding the boundaries of care outside of the hospital into the clinic, so that a personal health record or a health information exchange connects the patient from his episode with a general practitioner to when he sees a specialist, to when he's been treated for surgery and he goes back to his GP. I know how many patients have said, I saw 5 different doctors and everybody asked me, okay, now tell me what's wrong with you. And they had to say the whole Ramayana all over again. So now with the personal health record, which is the repository of the individual's health and all the episodes of care, a clinician can see this single view, which is in the custody of the patient or the healthy individual, and he is capable of sharing this with everyone in his care circle. So this transformation to say patient-owned, patient-controlled medical record, which flows across the entire ecosystem of care, is our personal health record idea. And this is something we've done for the last 7 years. We currently have over 8 million records, and anybody can build their record on and share it and store it securely and safely on the Apollo 24/7 platform. Many times people are taking medicines which are not efficacious for them. Many times we're following a care pathway when something else would have been more suitable for a quicker cure. You're taking an antibiotic, but something else would have been better for you based on the bugs which are growing in the environment. All these can come together by a combination of precision medicine and population health data. And that is, I think, the next frontier. As we go through these three layers, we will be guided, we will be empowered by various new tools which are coming up. I'm particularly excited about now the use of the HoloLens, augmented reality, and virtual reality, because as much as we need to treat individuals, we need to focus on training. And in training, a virtual reality-based environment, a simulation environment, as well as the virtual reality environment can come together to create far greater accuracy and precision and capability, use these powers and these tools, partner aggressively with tech companies and other companies to bring the best of the information and the digital era to our patients in a patient-friendly manner. These are small nursing homes. These are people in the rural areas and high-end, high-technology healthcare altogether. I think before I conclude, it is important to spare a few moments to really talk about the importance of taking every player along or bringing everybody onto this exciting new journey of information technology transforming healthcare, or the digital revolution, aided and empowered by the Ayushman Bharat Digital Health Mission. So I believe that over the next few years, all hospitals, small nursing homes, hospitals, etc., will have a powerful hospital information system, and data capture will be digital. And I will share an example that we were running for the government, for a state government, about 250 primary healthcare centers. We continue to run a large number of them. But when we started, we said that, we want all technology to be deployed in this area. So we put a simple data capture system or an EMR. We connected that to what is called a CDSS, Clinical Decision Support System. And then we added a voice recognition layer so that senior doctors who didn't want to type could speak out. So what I'm saying here is that people think that there are many barriers for adoption in a government primary healthcare center or in a small nursing home. But the fact is that in India, the cost of health information systems is not that high. The ROI on most investments made in the digital, if they're smartly made, of course, we shouldn't be buying the wrong technologies, but most investments. And because it's hosted on the cloud, you scale up as you use. Because of the nature of the structuring of these, they are not so expensive. So we must push for adoption and focus on the power and the value of the adoption. So in this primary healthcare center, when we started working, we used to have about 7 patients per day. Within a 2-year time span, this became 62 patients per day in a primary healthcare center average. And this is because customers or patients understand the value and the power of a quality product. So there was 100% digital capture. There was a connectivity with the nurse and the pharmacy who were in the next room. In case the doctor did not have a solution, he could connect via telemedicine into a centralized doctor pool of specialists, and he could have a teleconsult with the senior doctor immediately. This is something that nursing homes are beginning to understand. In fact, on the EICU project, we already have 180 beds which are not in an Apollo hospital environment. These are ICU beds which are connected to our central EICU. So this movement is happening in small nursing homes. It may take a while. We need the right vendors on board. We need the right platforms. But I will just say that if you use a cloud solution and not go into expensive servers, focus on training and doctor engagement, focus on customer outcomes and how things will be better in the healthcare environment, you will find adoption. And my kind of expectation is that within the next 2 years, you will see a high degree of adoption and connectivity in rural India and in tier 2 and tier 3 cities as well. Excuse me. I just want to add that, of course, we have enrolled into the Ayushman Bharat Digital Health Mission. We were among the early players. We have, been very happy to see that many of the recommendations we gave at the stage when Mr. Satyanarayana, who was our IT secretary, was putting together the report, many of those recommendations have been taken up. And we are extremely enthusiastic about the future use of a unified health information system and connecting our patients into that. Of course, I would like to add that this is customer or patient enabled. So at every point, we will keep individual privacy at the foremost in our journey in terms of sharing customer data. We will also be very clear that it's important to de-identify the patient, to mask and to follow all international security protocol. So Apollo is very committed to that. I want to conclude by saying that most industries have evolved in a tremendous manner. Whether it's the banking sector or even the retail sector, it's important for healthcare to transform, but it is more important for healthcare to transform because in every other area, it is an option or a convenience. In the healthcare sector, it's about saving a life or keeping someone healthy. So I would urge all my colleagues in the healthcare environment to get very serious about the digital journey. And I'm happy to, be a party to this transformation in our country and in the world. Thank you all very much and namaste.
Thank you, Dr. Reddy, for the wholesome conversation and adding value to our summit. Before we end, I'd like to thank our partners, presenting partner Optum Global Solutions India Private Limited, powered by Eka Care, co-powered by Navya Life Care, technology partner Cloudera, supporting partner Acnamed, and associate partner Kifid. We're grateful that you could join us today for the first edition of the FE Digital Health Conclave. The conclave is an overwhelming success, and we hope you had a great time hearing from our distinguished panel of speakers and networking with your colleagues. Please take a few moments to tell us about your event experience, since your feedback is of great value to us. We are on Twitter, Facebook, LinkedIn. Write to us. We are waiting for your emails. Please note that all the sessions will be made available on the FE Digital Health Conclave website for future viewing. Thank you again to all our partners, speakers, and delegates for allowing us to host you and be part of such an insightful event. We look forward to seeing you again soon. We have great events lined up for you: FE Radiology Summit, FE Pharma Awards and Conference. Looking forward, and keep watching us. Bye-bye.